Insulin is clearly not beneficial for patients in this specific context. Ergo, I got to find a way to prevent them from being on insulin.
If you do have high LDL cholesterol, you will have higher ApoB. But there's no other population, as you well know, that has extremely high LDL cholesterol, extremely high ApoB, low remnants.
Right.
Only lean mass hyperresponders have this. So we finally have ApoB and LDL cholesterol in isolation. And what do we see? We don't see an association between either with the progression of plaque.
What they found out was 1 in 12 individuals with an LDL cholesterol below 70 had a calcium score above 100. Okay? 1 in 12. That's a lot. That's a considerable number of people. And these are all people that had LDL cholesterol, presumably lifelong, below 70.
Tell me who you are and what you do.
Yeah, so my name is Austin. I'm a board-certified clinical pharmacist. I work in primary care. I work with 4 physicians, 2 internal medicine, 2 rheumatologists. I do a lot of medical interventions as it pertains to nutrition therapy, mainly with a focus to try to de-escalate medications for patients. So get them get them healthier.
Trying to put yourself out of a job.
Exactly. That's my goal. But one of the dietary approaches that we oftentimes utilize is a ketogenic diet, which, as you know, raises this one metric in a subset of individuals. I'm not sure if you've ever heard of it before. What? LDL cholesterol.
Whoa,
Hello?
This is new information.
Yeah. So we do a lot of those nutritional interventions. The ketogenic diet being one of many, but a very powerful one, indeed. And I act kind of like as a liaison between office visits. So when a patient sees a physician and their A1C is poorly controlled, or they have poorly controlled hypertension, or they get a calcium score or anything, they're typically consulted to me, and I act as their liaison between office visits. So, if you got a patient that came in with an A1C of 12% or something along those lines, they're not waiting 3 months in order to interact with another healthcare professional again, with their physician. They are waiting typically less than 24 hours to go over everything in detail, pathophysiology of what's going on in their body, how to mitigate that through lifestyle. If we need some medications to start off with, then we can do that, or they can defer, and then we follow them really closely for managing their chronic disease, or what I like to call reversing their chronic disease at this point in time.
See, you don't sound, either here or online, like a pharmacist in the way that I think many people, myself included, would normally think of pharmacists. We're thinking of the guy who's in the booth. You're coming with your script. You're saying, oh, yeah, I need, and then they go and get it, and then end of discussions, end of everything. That's the only time they see someone like you. But what you're describing is a different model. It's not just about matching the patient with the medications. You actually are deeper into the cases themselves.
That's right. Yeah. So I guess I would be more akin to an advanced prescribing practitioner in the care in the space of primary care, with a specific focus on what we would call polypharmacy, or individuals that have a lot of medications. And so that's kind of my wheelhouse, is understanding how all those medications interact, as well as finding ways to consolidate and de-escalate. So that's kind of my little niche within the pharmacy world. But you're right, pharmacy has a lot of different aspects, a lot of different professions that one can go into. So there's retail pharmacy, like you had mentioned, or community pharmacy is what it's commonly called. And that's where, they take a prescription, they review it for drug interactions, they ensure that the dosing is appropriate, makes sense for the individual patient, and then they provide any additional education to the patient at the point of sale. And I did work in that sector for a little while, which was very helpful for my current job, because it was one of the ways of understanding and navigating drug pricing, billing, things like that with insurance. So it certainly added a lot of value to help with aiding in cost control for the patients that I see now, and making sure that they can actually afford the medications that they're actually being prescribed. But outside of retail, there's compounding pharmacy, there's specialty pharmacy, which deals with very high dollar drugs. There is nuclear pharmacy. There's just a hospital pharmacy. There's a lot of different subsects of pharmacy. But my job is really unique. I'm in a collaborative practice agreement with my physicians, meaning that I have the autonomy to be able to start, change, de-escalate certain therapies, order labs, things like that. And it's nice because I feel like I get to do all the fun stuff with the patients, really following up on how they're doing and motivating them and helping them reverse their chronic disease without a lot of the stuff that I wouldn't be as, I guess, interested in, like, digital rectal exams and other things like that. That would not be very fun. Yeah. So yeah, I'm in a very privileged position. I love my job. That's my day job. My night job too. I am part owner in a company called Digital Conversation, and we do a lot of digital healthcare texting. So we help streamline communication between any sort of outpatient facility, including primary care, and the patients, just to kind of help them on their journey. I kind of think of it as akin to Tro's mission with respect to his app and helping provide education to patients, except for we do it without an app through texting. And I think the way that I think about it is it's a way to move the model towards more of like this interactive communication between visits, break the walls of the clinic, and make sure that the physicians and whatever care team is deploying the plan with the patient, that they can ultimately keep that line of communication long term. Because, no offense, 15 minutes in an office visit, you can't really get a ton of stuff done at that point in time.
It's not like you can just spin up those 15 minutes when you want and how you want. This is after you've set an appointment that's on the books. It might have gotten rescheduled. It might not have. You wait in the waiting room. You're trying to set things up. And then when you're put in the room, exactly when it is the 15 minutes appear, that's also kind of subject to time and availability by the clinician. So you're right. I mean, I could not be more in favor of more models that find a way to have the continuous care. And I think a lot of these concierge doctor models are accomplishing this in multiple ways. And it's good because I think this is what I think that there needs, I'm sure I'm not alone when I say there needs to be a change in the way that everything keeps moving further and further down that direction. I mean, it's 15 minutes today. That's after it's been shortened. It'll be like 8 minutes tomorrow. And for some, it is 8 minutes. That's kind of the challenge. All right. So that said, you do have an entire social media life. I think you could be argued to perhaps be, of pharmacists, one of the most up-to-date on lipid research in particular. And your journey and interest into keto is also what kind of brought you around to watching my story and the development of the lean mass hyperresponder research. Can you tell me how you first kind of came across this quirky phenomenon that we're going to be discussing?
Yeah. Well, my journey kind of came from two different spots, and then it kind of diverged together into one. But the first spot came out of basically my job and the frustration in primary care, in a sense that, every single time a patient interacts with a physician or comes to see me, it's, okay, here's your higher dose of the medicine. Here's another injection. Here is more pills and more cost. And patients are oftentimes not feeling any better. They're not moving any better. They're not breathing any better. They're not sleeping any better. Yeah, their metrics look better on paper, but in reality, they're just not really getting much better in general. And granted, I think there's one thing to prevent chronic disease, and there's another thing to really be able to make an individual feel better too, that oftentimes gets profoundly discredited. But in this sector of my journey, I got to this point, particularly with type 2 diabetics. I don't know if you know this, Dave, but so type 2 diabetics, when they end up getting so far down the line, usually what ends up happening is that the physician will put them on insulin, exogenous insulin, like Lantus, Basaglar, and eventually maybe even mealtime insulin. So those were long-acting insulins that I mentioned, then mealtime insulins. And the challenge is that when you're a type 2 diabetic and your pancreas is still secreting insulin, adding more insulin to a hyperinsulinemic state is probably not a good thing, as you may have as you may guess.
There's a lot of research behind this already.
Right. And so this is borne out in many observational studies, particularly with agents of exogenous insulin. And essentially, one might make the argument that perhaps the use of insulin in this context to lower blood sugars might prevent what we call microvascular damage associated with diabetes. So, there's two different big buckets worth of damage that individuals experience in the context of diabetes, one of which is microvascular damage. So that is eye damage, nerve damage, kidney damage, those types of things. And that tends to be more tightly correlated with glucose values in the blood. And then on the other side of the spectrum, there's the macrovascular damage, which are things like heart attacks and strokes, which are the things that typically kill the people that have type 2 diabetes. And so, the argument might be made that, hey, we're lowering their glycemia through the use of exogenous insulin. So maybe this is helping their kidneys, or maybe this is helping their eyes, or preventing them from getting peripheral neuropathy or nerve damage, like that very god-awful pins and needles tingling electric shock sensation. In fact, when you look at the data, it just doesn't really help with anything. In fact, it makes them sicker, usually makes them gain weight, predisposes them to very, very uncomfortable or potentially dangerous and life-threatening hypoglycemia, so low blood sugar that could lead them to having a seizure or coma or death. And so when you get to the point in therapy where you're reaching for that tool, I think that you're unequivocally causing harm to these patients. And so, as a pharmacist, I'm like, okay, I feel pretty comfortable with all the tools that I have in my toolbox with respect to medications. Insulin is clearly not beneficial for patients in this specific context. Ergo, I got to find a way to prevent them from being on insulin. And so I decided that I was like, okay, there's a lot of nutrition information out there. I'm just going to read as much as I can just to kind of try to piece this together and figure this out. Because, you hear one day that eggs are nature's superfood, and the next day that they're worse than smoking a cigarette, and everything in between. And it's just, no one knows exactly how to navigate that. So I stumbled upon Stefan Guigné, who's a well-known obesity researcher, does a lot with neurochemistry, neurobiology of obesity. And he created this website called Red Pen Reviews. Are you familiar with Red Pen Reviews? Yeah. So basically they set up a criteria for evaluating nutritional literature. And they look through the veracity of the arguments. They pick a couple of different claims that are in the book, and they do a fact check, and then they give it an overall score and stuff. So I'm like, okay, well, I'm getting into nutrition. I should probably start at a place that has maybe some rigorous standards as far as how they ultimately cash out a helpful book for nutritional interventions. So about the top 3. Which was Walter Willett's Eat, Drink, and Be Healthy. It was The Good Gut by the Sonnenbergs. And then it was The Longevity Diet by Walter Longo. So I read those books just in their entirety.
This is all before you're into low carb.
This is all before I'm into low carb.
Gotcha.
And so, I basically came away from those books with, we need to eat more plants, less saturated fat, less animal products, more fiber, protein, not a priority. But something that should be considered. And so I amalgamate all of this data, and I start going to patients with it. And it's just they've heard this stuff so many times, Dave, that it's their eyes just start to gloss over. I know I got to eat more whole grains. I know I got to do this. I know I got to get rid of my steak. I really like eggs, but I can't eat those anymore. I shouldn't be eating as many as I am. And bacon's definitely out because, that's going to give me colorectal cancer. So I'm just plant predominant, plant focused, this is by and large. And not only would patients not want to do that and were unable to adhere to that, but even if they did, I really didn't see a lot of great improvements in outcomes that I was expecting to see.
When they would adhere.
Even if they would adhere, which many of them did not. And this is a really important point that I want to come back to, which is this balance between the healthfulness and the maximal adherence of a diet. So we got to put a pin in that. But with respect to this journey, didn't see a lot of helpful changes for individuals, kind of frustrating. And then basically at about the same time, my wife was pregnant with our first. And so I'm about to have a kid. And, after my first kid was born, I kind of took a step back at myself, and I'm like, okay, I'm pretty unhealthy right now too. I look back at my lab now from where I thought I was, like triglycerides were like 154. I'm like, holy, and back in the day, I was like, oh, that's barely above, 150s.
Right.
Probably okay, right?
Right.
But no, 154, low HDLC, abdominal obesity, mild hypertension. I'm like, God, I really want to be around for my kid, for my wife, for the rest of my family. And, I wasn't like super unintentional about diet. I didn't really exercise at all. I'm like, I got to figure this out. And so I decided to kind of, look at those diet books, look at what Stefan Guinier, the calorie in, calorie out type of model. I downloaded MyFitnessPal. I cut my calories by 500. I joined the gym and worked out 5 days a week. I lost 35 pounds. But I was miserable. So miserable. Just hunger all the time.
High adherence.
Yeah. Right.
Poor quality of life.
Right. Exactly. And, I'm the kind of guy that can, white knuckle it for a pretty decent amount of time. When I set my mind to something, I feel like I can do it. But, there's two things that made that remarkably challenging. One of which was hunger was pervasive. It was horrid. And then number two was, I don't want to be like whipping out my phone every single time I eat food, particularly around my kid and my family and stuff. Like, it's kind of a bit of a challenge to, I want to be a good role model and, focus on good, healthy food habits. And, I think at the time I was like, yeah, this is probably not a great thing to do, to be meticulously tracking these things around, my newborn. And so one day at the gym, I stumbled upon Peter Attia's podcast, The Drive. And this was like old Peter Attia, like keto Peter Attia. Like Peter Attia back when he was like, at the Brazilian buffet and mainlining saturated fat off of like the, cuts of the meats and stuff like that, where he would tell all the stories in his YouTube videos. And he had Lustig on, and he had, Jerry Schulman and Richard Johnson, all big, like low carb, fructose, insulin resistance, metabolism kind of guys. And I just devoured it. I thought it was just so fascinating. And I was like, okay, I should. It sounds like the differentiating factor within this dietary pattern is that people can typically eat until they're full and maintain their weight or lose weight if that's what's desirable at that point in time. So that looked really attractive to me. And so I tried it out on myself. I lost another like 10 pounds with ease. Felt so good, and I was never hungry. I was like, this is amazing. And at the same time at work, we had a couple of more forward-thinking physicians, now retired, who were deploying keto diets or talking about keto diets quite a bit. So I'm like, okay, I got a couple of my physicians that are kind of like thinking about doing keto diets and stuff, so maybe we should just deploy this on patients.
Timing-wise, if I'm not mistaken, because the drive is about 2018, this would have been in 2018, right at the time that the name keto and ketogenic diets was starting to come up quick, right?
Gain in popularity.
Yeah.
Yeah. So it was kind of like a buzz. And it's interesting because my view of the ketogenic diet has changed quite a bit. Not only what it is in and of itself from where I was when I initially deployed it, but also what I think of it as far as like a nutritional intervention, how it fits with all the other ones. But the physicians, a couple of physicians were on board with it. So I started deploying it in patients, and it was, you've seen these anecdotes a bazillion times before, but not for everybody. But for a good chunk of people, particularly those that can adhere to it, it is miraculous, some of the results that we can see. I'm taking people off of 200 units of exogenous insulin in less than 2 weeks with a ketogenic diet. That is unheard of in medicine.
And it's worth emphasizing, for people who don't know, exogenous insulin is expensive.
It is.
And so they don't actually realize it's not just about whether you should be taking exogenous insulin or not and what's involved, with administering it. It's that it's freaking costly.
It's costly. It's a daily injection, often, sometimes more. It is one of the two top medications that lead to the most hospitalizations, that and blood thinners. It's it's just a challenging medication to manage. Physicians hate it. They hate starting people on it. You get started on insulin, go to endo. Endo will take care of you. Endocrinologists will take care of you. And so, yeah, I mean, it's a challenging. But yeah, I mean, so I start working with patients. We start deploying it, and it is going remarkably well. And taking people off of insulin, and seeing all these great results. And I basically accomplished the exact thing that I wanted to at the beginning. And then from then, it's just kind of devolved. And I'm one of these people that always likes to anticipate what could go wrong in a situation, just to make sure that I have an answer.
We share that in common.
Right. Make sure that I have an answer in case something does go wrong. And I remember when you were first talking about when you were exploring the ketogenic diet, you're like, LCHF. And you said that like, some people see a rise in their LDL cholesterol, but it's like a minority. It's not everybody.
Well, not me, the forums.
Yeah,
I was asking this about. Yeah. I was going, wait a sec, is my cholesterol going to go through the roof? And they were saying, it's like small number of people.
Yeah.
Hardly anybody.
Yeah. And so I'm sitting back to myself and I'm like, okay. So I'm telling this individual that, they can still have their steak for dinner. It's just instead of having this heaping pile of mashed potatoes along with it, just do some green beans. They can still have their eggs and bacon for breakfast. It's just instead of, doing hash browns and pancakes, maybe find some reasonable low carb alternatives to that, or just bag them in general. If you can take it or leave them, just leave them. And again, results are amazing. But then, you always wonder about LDL cholesterol rises in those contexts for these individuals. And at that point in time, it became my goal to ensure that I wasn't doing harm on these patients if, in fact, they did see a rise in LDL cholesterol. By the way, the number of people that I've seen have what I would consider to be a clinically significant rise in LDL cholesterol is like negligible. Okay, so most folks that I'm dealing with are metabolic train wrecks. Okay, so nowhere near the phenotypic characteristics or the characteristics of a lean mass hyperresponder. Most of my folks are, average BMI 35 to 45-ish, usually very poorly diabetic or very poorly controlled diabetic, hypertensive, high triglycerides, low HDL. I mean, just a disaster. So per your guy, well, I don't know if you were on that paper, but Adrian Sotomoto's, were you on that paper? Yeah. Fantastic paper, by the way. But, what we find is that individuals that are overweight or morbidly obese tend to see usually a drop in LDL cholesterol from a ketogenic diet.
From about above 35 BMI.
Right.
If they were going on a ketogenic diet. And this is in meta-analysis of RCTs. This was not observational. This was actually people were typically low-carb naive, like they'd never been on one. They would typically see their LDL cholesterol drop. And then from 25 to 35 BMI, typically no change, or at least what change there was moderate. So to your point, and I never feel like we can emphasize this enough, while we focus a lot on lean mass hyperresponders, it's kind of like at the same time, as much as this research is exciting, for what's going to be the vast majority of patients you're seeing, it's almost like, look, if you're metabolically challenged, there's strong data to say that the increase of LDL presumed to be in association with saturated fat is just not that common. And this meta-analysis is of RCTs,
right?
Randomized control trials. So it's pretty good data to suggest that.
Right. And not to mention, too, that, a whole host of other metrics that are much more strongly associated with cardiovascular disease tend to improve greatly, like hypertension. That's a big one. Hypertension improves dramatically on a ketogenic diet, in my experience. Now, of course, there are randomized controlled trials that look at this that aren't, as promising as what I've actually seen in clinical practice. But I would say, by and large, one of the most potent interventions to lower blood pressure tends to be a ketogenic diet. And I think it's really fascinating, too, because there appears to be some level of nutritional interaction between sodium and carbohydrate intake. And what I think was interesting is there was this trial that was published, I don't think it was too terribly long ago, but it was like a DASH diet versus a keto diet. So the DASH diet was, low fat, high whole grains, plant-based, salt restricted, so low salt. But then on the flip side, you had the ketogenic diet arm that was very low carb, no necessarily restriction on salt per se. And what did they find in that clinical trial was for individuals that had type 2 diabetes that were overweight, they saw more weight loss in the ketogenic diet. They saw more reductions in A1C, more medication de-escalation, and then they also saw better blood pressure control. And so what that tells me is that probably in this Western society that we live in, there's probably this big interaction between salt and carbohydrate intake. The higher carbohydrate intake you have in, probably the lower you need to go with salt. The lower carbohydrate intake you have, probably the more you can eat more salt. And then sometimes, in some circumstances, you must eat more salt in order to feel normal and good. Not get hypotensive and dizzy and lightheaded and feel like you're going to pass out and get constipated.
And you already know I'm one of these outliers. I'm glad I share this story because even though I self-acknowledge when I do that I am an outlier, there's a lot of lean mass hyperresponders. There's just a lot of people who adopt getting a low-carb diet, and the lower they go, the more ketogenic, the more militantly ketogenic I am, the more I just need to supplement more salt. That's, again, maybe an outlier, but there's enough of us that it's a story that's worth repeating.
Yeah, I completely agree. By the way, I have a question for you on what your journey was like to get to the point where you were actually taking salt tablets. Because, I have a subset of patients that will, adopt a ketogenic diet, be doing very well, but they'll still have some of these residual symptoms of the natriuresis of fasting. Nature meaning like sodium, rhesus meaning elimination from the urine. And it's typically associated with like a fasted or a pseudo-fasted state, which would be comparable to a ketogenic diet. And sometimes they're just dialing up on salt, and they still find that they're having some of these residual symptoms of constipation maybe, or of dizziness, lightheadedness, or the blood pressure's getting too low. And I'm like, well, I know this guy that's done like salt tablets in the past. I've yet to ever recommend one to. I mean, I've gone over it with a couple of my physicians. Like, we usually reserve salt tablets to the nephrologists. We're not like looking to typically prescribe a gram of sodium chloride to anybody in a tablet form. But tell me about your experience with that.
Yeah. So first of all, let me humbly acknowledge that of all the things that I've been trying to figure out in this whole journey, it was hands down the hardest one. And the reason is, I would argue is probably the reason for most people, almost everybody, is that it was easy to rule out. Oh, crap. I'm already getting plenty of salt. I mean, this is what I kept saying to myself. This, by the way, goes, the journey on keto started in 2015, all the way up until the fall of 2018. I had been playing with electrolytes back and forth constantly. And I kept ruling out salt because I felt like I was putting more than enough salt on my food. That could not possibly be it. And besides, the symptoms were more characteristic of things like low potassium or magnesium. For example, I would get foot cramps. I would get lightheadedness, can be a number of different electrolytes, to be fair. But feeling run down, that also can be a number of different electrolytes. But I figured getting the foot cramps, occasionally getting Charlie horses, that kind of thing, no, that's not going to be sodium. That's going to be one of these two, or there are other electrolytes. So I kept, for a while, I was taking something called sports salts, which was a nice complement of electrolytes. And I was just, I want to say I was taking 4 or 5 of them a day or something like that, and it helped a lot. I want to say maybe cut the frequency and the severity in half to 2/3. But
so 4 or 5 of those a day, and each one of them has a gram of sodium or a gram of sodium chloride. 500 milligrams of sodium.
Can't remember for sure. I want to say it was less than a gram of sodium. I want to say it was probably closer to, like, say, half a gram of sodium, something like that.
Okay.
I don't know. But I thought what was in the sports salts that were helping were the magnesium and potassium. As you probably already know, potassium by law cannot be that high in its dosage when you get it in a supplement form. And so I would get the Morton's light salt, which is potassium chloride, I believe, which is a way to get a larger amount of potassium. By the way, Not that anything we're saying here is medical advice, but people should be aware that you don't want to take a large dose of potassium in a single sitting.
Yes.
And ideally, you want to take it with food. Of the electrolytes, it is really, truly dangerous to have in large dosage all at once. Okay. So I'm learning all these things. And I keep playing with the amounts. And I keep going, I just don't get it. I don't understand why I have this issue when I'm keto, because I'm doing so well on keto. I love it so much. And then it's George Henderson who brought to my attention that it's possible the fructose malabsorption that I learned I had long before I was into this journey at all might be relevant with regard to my absorption of salt. It might have been to electrolytes in general, but definitely in the course of, in the case of absorption of salt or once broken down sodium in particular, that, and forgive me, I can't speak to the exact pathway, but the same thing that helps with the transport related to fructose malabsorption could also reduce the absorption of sodium. I said, well, that actually makes a lot of sense. If I've had this fructose malabsorption, it's been pretty bad, and I believe I helped to cause it along with my two best friends, who all three of us used to be chronic soda drinkers, downing super big gulps when we'd go to 7-Eleven every day while we're binging video games as kids. We all, by the way, developed fructose malabsorption. Coincidence?
So how do you diagnose that? Or how did you guys determine that you had fructose malabsorption? Or tell me about that.
All three of us were developing IBS into middle age. Very intensive IBS. And it was my friend Leroy who actually was the first to visit me here in Las Vegas and wanted to have the root beer that I was drinking, but conceded he's had to swear off all high fructose corn syrup because that was what gave him the symptoms of IBS. And I was like, wait, what are you talking about? Because I have symptoms of IBS. You're saying this does
is
that?
the stuff?
Right. What makes this even funnier to go 2 years earlier is I was suspicious that maybe soda had something to do with my IBS. And so I quit soda, and I was like, well, but I still want a sweet drink of some kind to replace it. I'll have apple juice. And so lo and behold, I didn't cease the symptoms when I replaced it with apple juice.
Shocker.
Yeah. Anyway, he says that I cut out all high fructose corn syrup. Sure enough, I don't have any symptoms. And then to further test it, my friend Andrew and I did an experiment where one day, after not having any symptoms for 2 weeks, I said, I got to test this, but I got to do it with a non-high fructose corn syrup thing. So I'm going to do it with apples. So we ate a bunch of apples. I was like, oh, this actually isn't too bad. I'm doing fine. That evening, I'm doubled over in pain. I could hardly stand it. So that was when I realized I do, in fact, have fructose malabsorption. Good thing to know, by the way, for anybody who's thinking about going keto, if you have this, you might find all of a sudden the symptoms cease because it turns out you had some poor, like we did. We had a problem with absorbing fructose. And I should say managing fructose would be a more accurate way of putting it. I should emphasize, by the way, fructose malabsorption, why it's so sucky is that you don't feel the symptoms right away after the bolus. And it's very inconsistent, but typically they would manifest anywhere from 12 to 36 hours later.
Mm.
So typically when you're feeling something and you think it was the thing you consumed, you're looking to the last meal. But often it was half a day later, sometimes 2 days later.
Wow, that makes it tricky.
Yeah.
So it's an inducible condition. So you had mentioned that you think that it was a function of how much regular soda you were consuming. So how does that work?
Yeah, as in because I was a chronic soda drinker pretty much my whole life, I would, and again, the symptoms are not consistent. So they would kind of come in and they would kind of go out, but there would be sometimes where I'd have gas pains where I couldn't stand. I was like doubled over, and I was, again, thinking to what I last ate, and I would cut out lots of different foods or meals thinking it had something to do with that, or maybe I had food poisoning. Just couldn't figure it out. But that was what cued off George Henderson to send me this paper. It's now been several years. I'd have to see if I can find the paper. But that convinced me to rethink whether or not I really was getting enough salt. And so finally I said, I'm just going to, for 2 weeks, I'm just going to consume salt with abandon, and I'm going to drink salt water. I'm just going to be making sure that I get 10, 12 grams of salt, at least. I'm gonna rule it out. And I got a blood pressure cuff just in case. It's gonna have the blood pressure, but as far as I know, I have no salt sensitivity, so my blood pressure doesn't go up, at least for me in particular. And I do it for 2 weeks, and all the symptoms disappear, like just completely. And I said to myself, it can't be that simple. It really can't. And since that time, there have been multiple times where I wasn't frosting my food enough because I was just going nuts with really upping my salt. Because when I was just consuming with abandonment, I found that I really could, for example, just put a layer of salt on my steak and on my cheeseburgers, and it was just making it tastier. Like I kept waiting until it'd get too salty. I put a lot of salt on my eggs, but that is one place where it can get too salty if I put too much. But I really can have it's very comical to be around other people when they're seeing just how much salt I'm putting on my steak, because to
twist off the shaker top and just
yeah, for real. I've done that many times where I'm just kind of like not just spreading a little anyway. But then at a certain point I said, well, this is kind of counterproductive because then I'm always needing to have at least one portion of food that I can really salt the heck out of. I'm just going to supplement. So I just started getting salt tablets. And now there's a number of people who do the same thing. They just actually take my recommendation because, like me, they don't need to supplement any other electrolyte. The sodium is kind of the trunk of the tree, as it was explained to me in this article. And I've not followed up on that, but in effect, that your body will ditch other electrolytes to preserve the sodium. I can't speak as much to the science behind that, but regardless, I do know this. Since doing it, if I always supplement enough salt, I don't have the other symptoms associated with these cramps, because it may well have been that supplementing in the magnesium and potassium was helping to reach some level of that depletion.
Mm-hmm.
But that ultimately the root cause came back to the sodium. It's possible.
So if you were going to potentially, again, not medical advice or anything, but, with respect to the sodium tablets, did you start with did you just do a conversion where you're like, okay, this is ballpark how much sodium I'm having per day. I'm going to just convert this into tablets and then just take the tablets with food? Is that typically what you did? Or
yeah, I'd like to say it was that, specific, but really it was just, I started with 2 tablets per meal, then I went up to 3, then I went up to 4 because I eat twice a day.
Okay, so eight salt tablets a day.
8 salt tablets a day, unless I've been doing it for a while, and then I scale it back to 3.
Okay.
But this is in addition to how much I salt my food anyway.
Okay. And GI distress was okay?
Yeah.
Okay.
If I'm on top of my salt tablets, I don't, and it's funny you mentioned constipation. That also just, any variation of that, disappears. That's
a huge one that I find. Maybe we can talk about GLP-1 agonists or something like that if you're interested in that. But one of the things that I consistently find is constipation in that population that start on these agents, and it's not fiber that helps very much. It's really not carbohydrate that helps very much. It's really not Miralax that helps, or Senna, or any of these pharmacotherapeutic options. Adding 2 cups of broth a day is by far my most potent hack for helping people with severe constipation on these medications. I mean, it works like I give it like a 95% hit rate. I mean, it's remarkable. But no one's thinking about those things because, sodium is going to make your heart explode and give you really high blood pressure and give you a stroke. And so I think it's just, I don't know, it's a bit of a challenge for me because I feel like, sodium issues might be hiding in plain sight.
I think that
for a lot of ailments, a lot of issues.
Look, we got to state it like it is. It's an essential mineral. That means you have to get it from outside the body. The body doesn't have a trick for compensating for its absence. You have to have it. We're very electrical beings.
Right.
So there's a reason why we need a certain number of minerals. Now, I think it's fair, as some people bring this up, where they say, well, wait a sec, ancestrally, do you really think our ancestors were consuming enough salt that would, be comparable to the salt tabs you've had? Probably not, but I think the fructose malabsorption might be a component to that.
It's a product of your environment.
Yeah.
You know.
That said, I'd be willing to bet our ancestors got quite a bit of minerals, frankly, because they weren't. Let's just say the hygiene of the food that they were consuming wasn't always the most ideal, right? So there was a lot more consumption of things via the soil that may not have gotten that on top of things like, for example, in eating meat, you would have more of the blood itself, which is a lot more electrolyte rich. Anyway.
In later populations, probably, preserving meat with salt to a degree. I mean, again, not like, Paleolithic ancestry, but I'd venture to guess they probably have more fresh kills and they're also eating. I mean, I would venture to guess they were probably eating one meal a day with a larger whack of protein, which can stimulate some level of an insulin response, which will give you a higher propensity to maintain a little bit more of your electrolytes. Whereas when we spread out our, individuals now on a ketogenic diet tend to spread out their meals potentially a little bit more than, maybe eating a huge, massive amount of food in one day or, every few days or something along those lines. And so that's another thing that I kind of think about too, is like maybe there was this large whack of protein, this large protein bolus stimulating an insulin response, which could potentially garner more of this like electrolyte retention to a degree. I don't know.
I think it's very individualistic on that spectrum.
For sure.
But that said, there's still a lot of context, especially when changing diets, that comes into play, which is difficult for us to tackle as humans because we so desperately want to make judgment based on shorter time frames. And that's especially difficult when you're working, I imagine, when you're working with patients, trying to move them out of a state of more metabolic challenge to one that's less so. And this is another area where I get a bit opinionated, is in this space, we like to celebrate the super success stories, but they can also be problematic because then the expectation of the people who go on said diet, they lose a lot of weight. They actually set their own personal records. But they don't look like that super Instagram model that, is touting that given diet, or their neighbor is losing the weight so much faster, or their wife and their husband going on the same diet seems to be cranking down the weight so much faster than they are. I wish that there was more emphasis for everybody on everyone's on their own health journey. It's a spectrum. At the end of the day, look at your own results.
Right.
Compare yourself to yourself.
Well, and the way I handle that too, because I mean, and again, with any sort of nutritional intervention as well as drug therapy and things like that, again, I got to bring the drug therapy up because I'm a pharmacist, right? But, the bottom line is there's a lot of heterogeneity. There's some people respond really well, some people don't. Even if you look at waterfall plots, which are plots that plot every single individual in a clinical trial and see how much weight loss they achieved with certain interventions, there are some people that lose a ton of weight, and there are some people that gain weight, and there's everything in between. And so, yeah, I mean, my goal and my focus typically with the patients that I interact with, though, I try to shift it more from a objective measurement of, your body weight on a scale to how do you feel as an individual. And I think that's helpful to a degree. Again, the goal is not to achieve some sort of arbitrary change in body weight or a specific weight metric on the scale. The goal is to make you feel your best, to move your best, to breathe your best, to achieve all of your functional capacity goals so you can do what you want for the rest of your life. And so when we kind of try our best to shift the focus from the scale to shifting the focus on how can I make myself feel my best and what can I tweak? And oftentimes, body composition comes with that. They're going to end up, losing weight if they're seeking, true happiness, not pleasure, because they can feel a lot better if they did a bunch of drugs or something like that. But in general,
or they could take down that pint of ice cream.
Yeah,
and
exactly.
in a moment,
get that big dopamine hit.
A lot of pleasure.
Lots of pleasure. But yeah, trying to strive for that level of true
feeling
happiness.
good around the clock.
That's right.
Like you're trying to get off the roller coaster of the binge highs followed by the deep lows.
Right. Exactly.
Coming from obviously somebody who really got excited about all the different metrics I could capture from blood work and the various numbers around it. I like that as a data nerd, but I would regularly discuss the measurement that's not there, which is exactly what you're describing, how you feel. I was feeling so great going on keto. And a lot of times I find I'm in this exact same conversation with other people who feel they should be a data nerd like me, and they should have a checklist of these different numbers, and then they're trying to hit this one and that one and this threshold and so forth. And it's a problem because it is true. The way medicine is geared, especially today, is doctors walking in the office and they've got the blood work right there. What's out of range, that's in the boldface, right? And that's what I was chatting with Peter about this just recently. I call it boldface type medicine, where you're just like looking at the line that's got the bold on it, and then there's the thing that you have, the intervention, which is typically some new prescription that's going to change that number to the number that's in range. So it's totally a numerical game. There's not as much of that focus on how do you feel. So anyway, let's steer this back to the story before we took a break of the salt, because you're now providing this ketogenic intervention to your patients. And I'm guessing, given you just already described your patient pool, it just doesn't come up that much that somebody actually sees their cholesterol levels rise. Because as you just mentioned with the meta-analysis, most of those who are very overweight, moving to a place that's moderately overweight or even to above normal, just slightly above normal, probably aren't going to see their LDL cholesterol increase, right?
Right.
But
the subset that go below, yeah, I mean, the propensity for LDL cholesterol to rise on a ketogenic diet, generally from the data that we have, which I think is borne out in my anecdotes as well too, or what I've seen clinically, is that, yeah, the lower the BMI you are, the more likely you are to see a rise.
When was the first time you saw one in your patient pool?
I don't have a lot, Dave, but I do have one in particular that is a fascinating kind of endeavor. So I work with a rheumatologist, and this individual, more of a researcher herself, very much into trying to, reverse engineer what is going on in her body in order to figure this out and ensure that she's doing the right thing, and alleviating this debilitating illness that is rheumatoid arthritis. And in a sense, it was, she adopted one of these like zero carb carnivore, types of dietary patterns. And yeah, LDL went sky high. Oddly enough, it was a substitution of butter with tallow that ended up resulting in a drop in her LDL from what we had seen on her metrics. But again, there's probably so many different variables that go into play there that like I'm not gonna like hang my hat on being like, hey, if you substitute this form of saturated fat with another form of saturated fat, that it's likely to make much of a difference. But it's been a really interesting case because the amount of improvements that have been seen in health have been, again, kind of to a degree miraculous. Being able to get out of bed and brush their teeth for some of these individuals that have rheumatoid arthritis is a challenge every single day. And to be able to alleviate that and de-escalate other medications and stuff. I mean, oftentimes individuals that are on, that have rheumatoid arthritis are on even sometimes chronic prednisone, which chronic prednisone causes glucose perturbations, changes in blood glucose, changes in fatty depot distribution. So they'll get deposits in fat in different areas. We call it the moon facies, where they have a specific type of phenotypic characteristic on their face. Osteoporosis is a big one too. So just to be able to dampen inflammation to that degree in that context is something that's amazing. And be able to de-escalate therapy within that context is amazing. And granted, there could be some level of a trade-off with respect to, maybe the higher number of particles or ApoB or LDL-C driving some level of disease. But in a lot of circumstances, people people look at other people on paper and they don't really account as much for their subjective experience. And that's something that really bugs me quite a bit. And I know you're privy to all of your anecdotes with, bipolar disorder and with schizophrenia and with severe depression and suicidality. And
there's a movie that's coming out about that.
It's a good one. And I think people discount that because they've never walked in someone's shoes like that.
Yeah.
They don't know what it's like to feel like you want to kill yourself. It's a strange feeling, I'm sure, for people to experience that. They don't know what it's like to have an epileptic seizure. They don't know what it's like to have bloody diarrhea for 5 days straight while you're in medical school, and almost lose your career over it. So, in this specific case, patient was like, well, if this disease takes my heart, so be it, because I can actually live. And that's something that is, I think, amazing. Now, luckily, with all the work that you guys have been doing, we have better ideas of mechanistically what is going on, what exactly risk is portended, or at least some reasonable inferences towards risk. And I think, for these individuals, we have some decent options as far as, if we want to hedge one's bets against the exposure model of atherosclerosis. In other words, the longer that you have higher LDL cholesterol or ApoB or LDLP, the more likely you are to have the development of heart disease that ultimately progresses to a clinical event.
All right, so let's get into it. You were there, getting back to listening to Peter Attia's podcast. Obviously, you heard me in, I think it's episode 13 or something like it's.
Oh, I thought it was like 4.
Yeah, it's definitely in the first, literally the first 12 or 13, something like that. I remember even asking Attia offline. I don't think this is in confidence or anything. I think he would agree with this. He himself wasn't sure if he was going to be doing the podcast because it was, taking up a lot of his time. I told him then, and I would say this now, is I think it's a good podcast. You should 100% be doing it. Obviously, that's borne out. It's a super big podcast. He's been doing quite well. But it is interesting because that was a unique podcast that I connected with him on that episode in particular. And I think you quite literally said this to me, that you probably hold the record as the person who's probably re-listened to it the most. It was 3.5 hours, right?
It's funny. I was going to give my introduction as the individual who holds the world record for a number of views of stress testing the lipid energy model with Dave Feldman and Peter Attia on the Drive podcast. But yes, I have listened to it quite a few times. And it was a fascinating discussion. I'll be honest. There's a couple things. I have some confessions. So first time I listened to it, I had no idea what the hell was going on with any of it. I'm like, what the hell? ApoC2 and C3 and all of this VLDL and stuff like that. I'm like, this is just wildly fascinating, but I really don't know what's going on.
Because it gets really technical.
It does. Yeah, it got really technical, and I loved it. And I'm like, God, I need to understand this because this seems really interesting and really relevant. And so, I kept going along, but I do remember the first time I listened to you on that podcast, which was the first time I was introduced to Dave Feldman. I was like, I didn't know what to think, because I was like, I'm embarrassed to even say this out loud too, because, I was almost in this old mindset of, the doctor is the king. Everyone else are just peasants. The doctor is the smartest one in the room. They're the most successful and they know exactly what's going on all the time. And here comes this engineer who, who seemingly knows more about lipids than Peter Attia, which is wild. And I'm like, God, this is just, I didn't know what to think of this guy. And then I think, so my first impression was like, is Dave Feldman really this nice of a person? Is he like this, or is he just like kind of like arrogant or something? Like I didn't really know, like I couldn't. And again, embarrassed to even say that out loud. And then I heard you with Ivor Cummins on the podcast that you did right at the Gaylord convention, where you guys went through Peter Attia's prebuttal, where he had those 3 points that he went over, the mass balance and genetic alterations.
For anybody who doesn't know what we're talking about, so the 3-hour podcast that I did with Peter, he did do. I want to be as generous as I can, but there's just no getting around it. It was something he's never done with any guest. I actually don't know that I've ever heard any podcast do this, but he kind of summarized what basically why he felt what I was about to say through the whole podcast. He summarized why he felt it was wrong. And he had 3 points that he was making with regard to, so it was kind of like a rebuttal, but really a prebuttal, because it was kind of assessing the whole podcast after the fact, putting on the arguments against what I was saying on the front end. So I was, and it did cause quite a stir within the low carb community, but I was still very thankful to have been able to appear, to have been able to make the case. But I will concede, I had a little bit of a tough time with it, only because I felt like it may have prevented a number of people who would have possibly listened to the case as it was made, and might have helped drive better discussions around it.
100%. And by the way, what you just alluded to is why, I just think that you're an amazing human being. You're like, yeah, I really appreciated the opportunity. It was amazing to go on there. Most people would have been like, what the is this guy doing? He did this to me. I mean, he poisoned the well. He poisoned the well of a fantastic discussion between a brilliant engineer and a lipid nerd physician, by basically setting it up as a prebuttal to a conversation that people should go and draw their own conclusions from. But the fact that in that interview with Ivor too, you're just like, yeah, I wanted your introduction with Ivor. I just want to thank Peter again for having me on the pod. You're just a great human being, Dave. You just really are. I envy that aspect about you too. That I think you're just such a kind and genuine human being, and that's why I'm so glad that you're leading this movement and pushing forward with it. Because there are some people that I feel a little bit more skeptical of, and or might be a little bit more reductionist on both ends of the spectrum with respect to
100%.
Whether it's keto or whether it's we need to give statins to every single person in the population.
And listen, thank you for the kind words. I will confess, you've also seen behind the scenes, Dave, I do have my moments where I'm probably a bit more salty about some things. And so I don't want to suggest everything that I do publicly. This is what I like to think. I like to think I do my best to exhibit what really are there. It's like present as far as my appreciation of this journey. And I say this many times, it's worth taking one more moment to say it again. I really do believe many people, and this includes Peter Attia, I really do believe that while there may be multiple components to doing things like the prebuttal, a large component of it is a genuine concern of harm. That the concern is the theories that I'm discussing, even the research that I'm pursuing, could be overly relied on by people who it may be harmful to, or that these doctors would believe that they're going to now make decisions that will ultimately result in harm. Now, I say that, but I will say in my defense, I do still think we can't avoid having the conversations.
No. Because
you still do have a trust metric, and we should still be productive with each other, right? Like there shouldn't be pretense. There shouldn't be, ideally, we shouldn't have to do prebuttals, right? We should be able to have the conversation and, have what the best that people can conclude be, as well as to further talk about it after the fact.
Mm-hmm. Mm-hmm.
And the beauty of today is, we're about to talk literally about what's happened 7 years since, where we actually have data in hand that actually leads back to these original conversations I was having with Attia. And, the conversation continues, right, across the land. What's so fascinating about that, though, is I think I've told you this, I have a donor who literally wants to pitch some funding for me to do a respectful reaction back to that podcast, because I haven't listened to it. I think I listened to it one time since it had happened, after it come out, but I hadn't actually listened to it all, like yourself So
I'll do it with you. Who knows?
Yeah. But yeah, I would be interested to know how many things I feel differently about from what I said then versus now. And also just kind of reflect on how little hard data had been collected by that point, because this precedes the Citizen Science Foundation. This precedes the whole fundraising effort. I was still in the process of trying to talk people like Peter Attia and Thomas Dayspring into being interested enough to do this research. I think, if I'm not mistaken, at that time, I was just trying to get a data set that I could look at the triad in a clean fashion.
Just stratify it. Yeah.
To stratify it so that I could see if, just in general, those people with high LDL, high HDL, low triglycerides, at least to see if they had greater cardiovascular disease or, for that matter, all-cause mortality.
Right.
And that was 1 year before I got a hold of NHANES to kind of run my own analysis on that. But, regardless, I genuinely, I really did appreciate the opportunity, and it did open some new doors. So
that's good.
Yeah.
I think too, like, probably reflecting on that video, and I know, again, I've seen it a million times. I don't think any of your positions have really changed at all, to be honest. There might be like some maybe slight mechanistic nuance that has changed, but by and large, globally, I think you've been consistent even before you had the data with that podcast.
I think that's true. I would have had a better answer today on the mass balance than I did before. Mm-hmm. I didn't have as much appreciation for, I'm going to try to steelman Tia's position, that because the lipid energy model did not take into account the full deposition of where these cholesterol esters went that were on board the ApoB lipoproteins, it therefore could be invalidated. Now, to be fair, I argue that that's not the case. You can't invalidate a model entirely based on one thing it doesn't yet take into account, since the primary focus was on the triglyceride delivery. That said, do I have a stronger sense of what it was he was interested in, where I think it goes? You probably already know this by now. I do. I believe that there's a greater endocytosis of these ApoB lipoproteins, quite literally for use, quite literally to incorporate into the lipid bilayer so that they can accommodate the expansion. And I believe people like myself, like Nick Norwitz, but particularly people who are leaner, actually have much smaller adipocytes and therefore have to expand and contract their adipocytes, maybe teensy tiny amounts. But that said, it's going to have a substantial impact on these overall particle numbers, if that turns out to be true. I don't know yet.
It's blasphemy, Dave.
Yeah.
Every cell can synthesize all the cholesterol that it needs. No, it's interesting that you say that too. There's a couple of points that I want to touch on, but with that specific point, I was reading this response to retention paper written by the father of response to retention. I forget what his name is, it's escaping me right now. But he suggested, there's probably a pretty high likelihood that, LDL and its component cholesterol and phospholipids and other things, in certain circumstances probably are required by certain cells to uptake and use for different purposes, etc. Like the Home Depot analogy, where you got a Home Depot, drivers driving around your neighborhood all the time, kind of grab a couple of pieces of wood and maybe a couple of nails here just to, I venture to guess it's got to happen quite a bit, but the level of detail and science that's probably required to elucidate that to a great degree is probably hard to do. And so, we'll probably have to find ways through maybe some indirect evidence in order to figure that out. Or I don't know, maybe you guys will do some tracer studies or something like that. But
some things like mRNA at least let us look at the instructions towards making the receptors towards. Now we have the SRB1 for understanding the transcytosis a little bit better. Why would nuclei actually be making these instructions to have these transports if they're not actually going to be in use for some reason? This is why. Sorry, we're jumping straight into ultra geek mode, but we want to do that anyway. This is why, I'll state this up front. This is one piece to the conversation I was having with the Tia that I've talked to you about in private that I'll just go ahead and air here, which is one that's pretty exciting to me. it very well may be that folks who are super lean, the highest level of lean mass hyperresponders who see the highest level of LDL cholesterol when going on a ketogenic diet, that we're going to ultimately find that they do the most transportation from the lumen in the vessel to their adipocytes through endothelial cells via transcytosis in order to accommodate that expansion contraction cycle, right? Particularly the expansion part. And if that's the case, if indeed, and I've talked about this with Nick Verhoeven, if indeed there is more transcytosis on net to meet structural demand, that would actually put it directly at odds with the present-day lipid hypothesis. So the present-day lipid hypothesis is now at a place where transcytosis is thought to be part of this initiating process to the response to retention. Basically, the more you're playing that, I like to call it the lottery you don't want to win. That's how they would think of it, right? That eventually you've done one too many transcytoses where you're going to have that ApoB particle that gets stuck. And it gets stuck and it gets modified, and then the macrophages come, and then I like to call it the macrophage theory of obesity, which is that they come and they eat, but they don't move for whatever reason, and then stay there, and then they're attended to by other macrophages, and there's just no getting around it. It has to keep growing, this new plaque. Okay, if that's true, if it's true, and I don't know if it is, and that would be extremely hard to elucidate, if there is more of this transport at a higher rate, then there should be more opportunity for these ApoB lipoproteins to get stuck with lean mass hyperresponders. And if we have data that is not showing this development of plaque, that would be incredible.
I agree. Yeah. And there was actually a study that was published that LipoFan, who, by the way, is just a genius.
Shout out to LipoFan.
Shout out to him.
Lipo_fan on Twitter.
Absolute genius.
Let's just be an advertisement for him.
Yeah.
He is constantly putting out cool threads. Does a really good job of digesting. He takes little breaks from Twitter, but then occasionally comes back on. But I just have to say he's a gold mine, a great resource.
What do you think his profession is, Dave? An engineer. Wow. Who'd have guessed that? Who'd have guessed that? Jeez Louise. Knows more about lipids than 99.9% of lipidologists. But yeah, he did a recent, he put out a thread on a recent publication with respect to how the response to retention needed an update to a degree, in a sense that the rate of transcytosis had nothing to do with the amount of ApoB containing lipoproteins that were actually retained in the intima. That it was more of a function of the fly paper, so to speak, rather than the flies. So the proteoglycans, the things that they were binding to, ended up being the differentiating factor. Don't ask me why, don't ask me how, don't ask me what modulates that, because I don't know the answer to that. But the bottom line is, to a degree, I think right now we have some decent evidence to suggest that the rate of transcytosis doesn't necessarily perfectly translate to increased plaque, or at least it's not stochastic in nature to the degree where it's just like this random distribution where the more particles that are crashing your arterial wall, the more likely you are to get atherosclerosis. I did kind of talk about this in Tro's podcast too that I did a couple weeks ago, but it's like these, just from a pure physics standpoint, it's really hard for a little particle, I think, to weave through a glycocalyx, find its way to, the endothelial cell where it's got a lipid bilayer, and try to shove its way through all of the components that are in the cell, and then boop, get right back out, or squeeze through these 3 to 9 millimeter tight junction gaps that, when in fact the particle is 3 or 4 times that size. It just, steric hindrance just is not going to allow something like that to happen. So it's got to be an active process. And if it's an active process, evolution isn't stupid. It does things on purpose. And sometimes that comes at a trade-off. But, I think in this circumstance, I don't know, we could speculate on mechanisms all day long, but
sounds like you might have seen my transcytosis talk.
Yes. By the way, I do want to rewind 2 seconds too, because there is a lot of, back to the Peter Attia episode too, there are a lot of straw man that go along with this whole idea that just because of you, people aren't taking statins or something along those lines. It's Dave's fault or something along those lines. I think there's two important things to note. Number one, I strongly believe, I don't say this often, but I strongly believe that improvements in your global metabolic health are going to cash out in not only a lower risk of cardiovascular disease, but all-cause mortality, period. Okay? So, and this might be a controversial thing to say, you might not share this opinion with me. But I think if everybody in the world just forgot about their LDL cholesterol and really focused on getting more metabolically healthy, building more muscle, losing excess fat mass, I think I would suspect that as long as we didn't, adopt a huge level of smoking in our population or had some other environmental exposure, I venture to guess that atherosclerosis would be largely an orphan disease. That's an overstatement, okay? I'm okay with that right now. I'm one of these guys that has, I hold my positions loosely. I'm always willing to change my mind. But I think oftentimes people are like, well, look at Dave, like he's telling everybody to ignore their LDL. You've never said that, by the way, ever in your life.
Never.
But even if you did say that, for all of these folks that, wouldn't have adopted a ketogenic diet, that would have continued their whatever diet and tried to focus on their LDL or whatnot, I would say that the number of lives that you've saved through this process by garnering awareness for a ketogenic diet it's amazing, and it's admirable and absolutely incredible. Okay, so then let's look at the other side of the ledger too. These people that come into Ethan Weiss's office and says, I don't want to take a statin because Dave told me so. The thing is like this is my wheelhouse. This is what I encounter on a daily basis. I get 2 phone calls about meds the most. One of them is bisphosphonates, which are osteoporosis medications, alendronate, resendronate, abandronate, and then Prolia and other agents like that. I don't know what they write in that package insert, by the way, because they must say like this drug is going to kill you or something in there, because people call me about these medicines all the time. The other number one call is about statins, and they're afraid that they're a metabolic poison, they're going to kill me. They're going to give me rhabdomyolysis. They're going to make my muscles turn to mush. They're going to give myself dementia and things like that. And so this is one of the common, and I will tell you, Dave, I'm ready for it. I love these conversations because they end up trusting me at the end of these conversations because I can lay it out to them. I can level with them. I can say, there's a little bit of truth to what you may read that these medications can increase your risk of diabetes, or some individuals do experience muscle aches, pains, and weakness on these medications. And, it's my job to kind of assess their full clinical picture, give them the evidence to make sure they understand what we do know and what we don't know. And at the end of the day, I don't care if it's the nocebo effect or if it's a direct effect of mitochondrial toxicity or whatever. If someone's waking up a week into taking their rosuvastatin 5 milligrams and they're having muscle aches, pains, and weakness, we're stopping the drug and we're moving on. We're going into different aspects of care. So the bottom line is I think for those kind of individuals that would say, I'm not taking a statin in front of their cardiologist because of Dave, there's nothing in the world that's going to convince them.
Yeah,
if you as a clinician have a patient like that and you can't convince them based on the evidence that you understand and that you can deploy, I think you've failed as a clinician. And that's just my opinion.
No, but the point you're raising is very germane in that you don't even have to be in this space very long before you recognize humans do what they do in almost anything, where they want to make a decision and they want to grab the nearest thing that's near that they can utilize and leverage to justify their decision. So before me, there were many other ways by which they could be comforted as to why they might want to have, say, high LDL, right? And after me, there'll be whatever the most prominent voice is that's speaking to either high LDL or the problems of statins. And one of the challenges is, as you know, I'm trying not to be in a position where I'm saying either thing, because a genuine scientific position that I hold is mostly one of unknown. I don't know. I genuinely don't put a lot of time into reading up on statin studies. Do I think there's a trade-off? And quite literally, every intervention you ever make, yes, and that trade-off may be to your benefit. But do I think there's any true free, there's only benefit in a given intervention? And you should always start with that assumption, no matter who you are, no matter what population. No, I've never had that position with anything, right? So I don't want to be in the position where folks are saying, okay, well, look, if there's some people who might benefit from it, what do I need to show you, Dave, so that you then start saying, do this intervention? And I'm going to say, that shouldn't even be a conversation anybody should have with me. They should have it with their doctor. And exactly what you said, it's between them and their doctor. The doctor shouldn't be coming to me on the outside and saying something you're doing is having an impact on my care, particularly given two things. One, I regularly and quite frequently emphasize I'm an engineer. Don't confuse me with it. It's funny because I've actually had a number of my co-authors saying, you can say you're a lipid researcher. You quite literally are published. You now have a study. And I said, I may say lipid research is a thing I do, but I actually will always think of myself as an engineer, above all else. But the other part is what I think I appreciate so much that you do, that I see other doctors do, which is that if they're a good clinician, they're already trying to wrap the context of that individual patient in, including what their desires are, right? And certainly my hope comes back to the thing you mentioned just before this, which is metabolic health itself. Now, you and I both know on social media, because it's right there for the world to see, there are a lot of clinicians who say, okay, I believe both. I believe you should improve metabolic health. I believe you should lower lipids. I think this is really high. Metabolic health is far more relevant to not just your overall health, not just to mortality overall, but to cardiovascular health, to the health of your heart. And yes, if you're really going to just ignore this, in spite of my pleading and begging you to do something about it, we have some ways to try to mitigate it, and lipids is one, and it's down here, right? There's a lot of folks I know that fall in that category. There's this sort of new category, which definitely our research is a large component of it. Folks that are saying, well, you're in good metabolic health currently. You now have high LDL from going on a ketogenic diet. Let's do some imaging. Wait, you came back, in this case, with good imaging? You have both good metabolic health, and your imaging shows you're low to no risk? There's just no data that suggests we should do something about your lipids. If either of these are not the case, those same doctors would say, I would feel better if you did something about your lipids. And I'm fine repeating what they say, even though that's not me giving advice. I'm just saying that this silo is starting to grow up. But there are some folks, there really are some folks who think it's flipped. Metabolic health, you should do something about metabolic health. But at the end of the day, it's all about the ApoB. You've got to get the ApoB down. It's mitigated by that. Things like primordial prevention is a new phrase that's used to suggest we could make atherosclerosis or just heart disease via atherosclerosis an orphan disease today, even in metabolically unhealthy populations, just by getting the ApoB low enough.
So, first of all, when I counsel patients on heart disease risk, I say probably the number one mediating variable, based on the data that I've read, is your overall body composition and your metabolic health as far as how long you're going to live on planet Earth and what your recurrent risk of cardiovascular disease is. It's really hard to point to exact ironclad data to support that position perfectly, okay? But I think that there's lots of data out there that we can make very, very reasonable inferences on. But even if it wasn't the case and LDL was more important, I think even just telling patients that, you are really addressing a level of residual risk in that individual. Because the bottom line is, and Dave, obviously, like I'm a pharmacist. I'm probably one of the more, medication heavy people that you're going to be on there, even though on this podcast, even though I probably am the least medication heavy at my current practice that I work at. But the bottom line is if someone comes in that has, clinically significant detectable plaque on their CTA or their CT scan, their coronary artery calcium score, I'm typically throwing the kitchen sink at them. From a lifestyle perspective, is the number one thing that I always want to be hammering home with these individuals. And then I meet with them for where they are with their personal goals with respect to, medications. But, the data are pretty decent in individuals that have higher calcium score. You're likely to see a proportional amount of benefit from lipid-lowering therapy by the degree of atherosclerotic burden that you have within your blood vessels. And so in this case, it's a little bit less, I love the academic discussions, but for me, it's a little bit less controversial. But what I think focusing on metabolic health with in the utmost being that the center of attention is not only does it give them motivation to prevent having a heart attack or a stroke or something along those lines, but it makes them feel a lot better too. And that's, again, one of the things that we oftentimes forget about. People get so complacent with feeling so crappy as they age. Like, aches and pains. I feel depressed and anxious and stuff.
Just comes with getting older.
It just comes with getting older. This is just how it is. And I want to be the person to say, it's not. You can feel better. And I can help you do that. And, the problem is that statins are not going to make you feel better. If anything, they're going to make you feel worse. Hopefully they don't make you feel anything at all, like you're taking a placebo pill, like Khram Nasir likes to say, a multivitamin for the heart. But in general, the thing that's going to enhance quality of life the most for this person is going to be nutritional and lifestyle intervention. And then we're going to get that added bonus of lowering the risk of cardiovascular disease, which is, I think a fantastic thing. But, to dovetail into your point with respect to, and I'm not even sure this was the exact point that you were making, but there is this subset of individuals on social media that will say, yeah, metabolic health is important, but why not just do both? Why not have your LDL-C low as well? And not have it, sky high and stuff too. And I think this is a fascinating discussion. And I think it's interesting the different points that this ultimately cashes out to as to why some people take that argument seriously or don't take that argument seriously. I would say this. Number one, there are some folks, which is clear from the documentary, which, by the way, was brilliant and amazing. So well done.
Just to level set, you're talking the cholesterol code movie.
Yes, right. Yes. So excellent work. I know I've told you that already, but for everyone to hear. But, there are some people that by all means, they've tried a lot of different things, and there's nothing that's going to help bring their LDL cholesterol down to a significant degree. There was a case, I don't know if I can share the case in the documentary of the individual that had bipolar disorder. Is it okay if I kind of...
Yeah, just don't reveal anything in the third act.
Yeah, I won't. But, I'll just keep it general. Individual has debilitating mental illness. Individual is lean, sees LDL cholesterol rise, works with their doctor to try to find ways to mitigate that, including carbohydrate reintroduction. And unfortunately, what happens is that with the carbohydrate reintroduction, LDL cholesterol goes down, mental illness comes back. And again, with the debilitating type of mental illness and this specific anecdote that was in the documentary, it was heartbreaking to see that. I was crying in the middle of the theater because I got kids, and I think, what if that was my significant other? What if that was my mom or dad? These are all things.
Because that story isn't just about her.
Right.
What I love about what we captured in that film was that story was more about her family and her relationship with her family being impacted. It wasn't just her depression.
Right.
It was how it was significantly keeping her away from the family dynamic she was finally coming back into contact with.
And it was just so beautiful to see her interact with her kids when she was in that great mental state and feeling happy and feeling joy and just having that flat affect when she was back in this state of fog of mental illness is just, again, heartbreaking. So and then again, I would wonder about that individual, like if they were sitting in front of me, maybe we would try ezetimibe. maybe we would try a PCSK9 inhibitor. Maybe we would try, if she could afford a PCSK9, or the individual could afford a PCSK9 inhibitor or whatnot. Maybe we could do something just to kind of like, quote unquote, hedge our bets. Obviously imaging is remarkably important, but the bottom line is like, with Nick Norwitz, who did his orioverstatin on a high intensity statin, rosuvastatin, 20 milligrams, which is a very potent dose. The only higher dose is 40 milligrams. He saw a very weak LDL cholesterol response. How much benefit is he as an individual going to experience from that reduction in LDL cholesterol? I don't know. I would venture to guess that would cash out in something that's clinically insignificant over the lifespan of a human being.
He himself also had side effects
and
on the
sure.
statin.
Yep. And it makes a lot of sense as to why he would, right? Because of, the way mechanism of action of which statins work is inhibiting cholesterol synthesis in all cells, but predominantly the way that it works to lower LDL cholesterol is to inhibit cholesterol synthesis in the liver by inhibiting an enzyme called HMG-CoA reductase. And HMG-CoA reductase is probably an important enzyme for individuals that traffic a lot of fat in their body.
That's our hypothesis.
Yeah. Don't know for sure, but bottom line is it's there are some individuals that really don't have much of a choice. But on the flip side too, for the individuals that do have a choice, again, I think with respect to LDL cholesterol, ApoB, LDLP, etc., I think it's really important to balance dietary adherence with the healthfulness of a diet. And the bottom line is dietary adherence that is likely to cash out on improvements in body composition is remarkably hard to maintain. It's really hard to argue with that. Adherence to a dietary pattern long term is remarkably challenging. And so I think any way that we can maximize an individual's ability to adhere to a dietary pattern that is going to improve their body composition is worth the trade-off of any sort of perturbation in their LDL cholesterol. Now, I don't know if that's universally true. There probably are some exceptions and some strange circumstances. But I think by and large, this is one of my crusades, which is this overemphasis on LDL cholesterol, LDLP, ApoB at the expense of maximizing a dietary approach that someone could stick with long term to improve metrics that more strongly associate with heart disease and quality of life, like your body composition. I think you're doing net harm when you're myopically focusing on, this LDL-C metric, this ApoB metric, and people are like, we gotta, tell everybody to substitute saturated fat for PUFA and MUFA, and that'll lower their LDL cholesterol or increase fiber. It's like, you are missing the forest through the trees.
We share this so much. There's I keep trying to find a new way to state this more and more directly, more and more emphatically. I just don't know another way of putting it other than I feel as though cholesterol focus is a disastrous distraction. I just don't know another way of putting it. You can believe the lipid hypothesis. You can believe that higher LDL is detrimental and then rely on the best data that we have to suggest taking action on it could be of benefit. But if you're relying on the best data, you have to also acknowledge the data that's all around insulin resistance syndrome, all around hyperinsulinemia, and just how catastrophically more multifold worse it is. And the problem is that this hyper obsession with trying to manage lipids is very suggestive of it being the predominant area of concern, that your diet has to completely conform around it. And again, those folks who say, let's just do both, there's still a brighter spotlight by far on the lipids than there is on what dietary intervention, as you're suggesting right now, which is I'm sure is where you're going, that can actually improve their entire metabolic spectrum. There's just no question that given the option between those two, if they're at odds with each other for somebody who's just trying to find a way out, I'm saying head towards metabolic health first, as best as you can, We can talk about, again, those who believe that whatever your optimal state of metabolic health, you could still be better off with lower LDL, right? We can still keep that in the room and as part of the conversation. But the weight, again, in the best case you can make for it, is so much smaller than it is for metabolic health overall. And I've ran headlong into this. As you know, I've shared with you privately a number of the challenges that I've had within my own family, and how much there's just so much attention that is played to lipids at the expense of the attention that I believe should be paid towards metabolic health.
And that's the problem, is it's at the expense. Because again, I'm like I mentioned, I have the privilege of being able to speak with my patients for a lot longer period of time, be able to counsel them on the risks, benefits of everything that's associated with it. And granted, when I'm seeing clinically significant disease, I am throwing the kitchen sink at them. And that includes aggressive LDL management if that aligns with the patient's personal goals. But it's really hard to argue with the fact that, the order of magnitude of adjusted hazard ratio in the Women's Health Initiative of LPIR, lipoprotein insulin resistance score. Thank you, Dr. Cromwell, for generating that. But it's a fantastic, almost primordial measure of the lipid changes that occur in individuals that precede things like diabetes and hypertension and other metabolic perturbances by years and years and years. And the adjusted hazard ratio for a female under the age of 55 is like 6.51 per standard deviation of LPIR, 1.81 for ApoB per standard deviation. So again, we're looking at things that are orders of magnitude different. And the other challenge too is this little well-known fact called multicollinearity. And ApoB is one of these metrics that's weird. And so you'll get a lot of pushback from people that are trying to analogize ApoB to smoking, to hypertension, to glucose abnormalities. And I think that is just a grave mistake. It doesn't make any sense to me, because I can't think of a single circumstance where in a fasted, without any sort of exercise or whatever state, hypertension would be typically a good thing, or having really high glucose values and stuff would be a good thing. And all of those metrics, including ApoB, by the way, on a population basis, tend to track together. The more metabolic syndrome criteria you meet, the more ApoB tends to go up, the more all these other quote-unquote risk factors tend to worsen. We have this weird circumstance with lean mass hyperresponders where the more they exercise, the higher their ApoB goes. The leaner that they get,
depending on the nature of the exercise.
Yeah. Let's say light cardio, maybe, or if they're lifting weights, maybe where they're doing a little bit of that, endocytosis in order to meet demands of the muscle tissue and to grow or whatnot, structural growth and repair. But by and large, triglycerides are going down, HDL is going up. That is proportional, typically, to the rise in LDL cholesterol that is oftentimes seen. And so this is why I think the lean mass hyperresponder phenotype is so much more generalizable than people give it credit for.
I agree.
Because it speaks to the broader lipid metabolism. It speaks to the constellation of features that culminate in this triad. And ultimately, ApoB ends up being probably more of a function of a marker of risk rather than a maker of risk, in my opinion. Now, again, I'm probably going to get murdered by the lipid community for even saying that. Which, by the way, is wild that we live in a time where things are so divisive in different communities that even to suggest something like that would just, make people lose their minds. But the bottom line is when you're getting more metabolically healthy and your ApoB is rising, it's probably a function, ApoB level in your bloodstream is probably a function of the ratio of carbohydrates to fats in your diet in an insulin-sensitive individual. And I don't think the ratio of carbohydrates to fats in your diet probably cashes out to that much of a difference in your atherosclerotic risk or longevity, which is why I think non-HDL-C to ApoB ratio is such a fantastic metric.
We all come back to the...
Because what that's looking at is your ApoB is dictated by something.
Right.
Your ApoB is dictated by how much fat trafficking you need to perform in order to meet the energetic demands of your system. And so you can see ApoB go up in the context of hypertriglyceridemia. There's no doubt about that. And we should probably just nerd out a little bit and go through, how that all works and stuff. But the bottom line is ApoB skyrockets on a population basis, not because people are adopting low carb diets and going and running marathons and stuff. ApoB is rising on a population basis because people are getting metabolically sicker. And that's probably why it tracks kind of crummily with outcomes. It's still not that good of a great of a metric.
Right. But that's crucial, because if you're watching for the correlation of the drop in ApoB with a benefit, if you've got an intervention that's going to result in lower ApoB, let's say that we're getting people to exercise a lot more and they're dropping weight, and now their LDL cholesterol is going down as well as their ApoB. Their ApoB is coming down substantially, right? How much of that is a resolution to what's clustering with it because of how that impacts the lipid metabolism? Well, you already know what I believe. It's literally in our lipid energy model paper when it's comparing lean mass hyperresponders with atherogenic dyslipidemia. It's a bit of an oversimplification, but you know what I mean when I say this. You've got more vehicles in the bloodstream, either because there's just more need to traffic what their cargo is, or because there's more of a traffic jam. At the end of the day, the cluster of the bad things come with the traffic jam, and it makes sense because part of what they're delivering is failing to be delivered. And there's an easy way for us to test this, which is to go with the other model, find out for those that are successfully trafficking, successfully delivering what their cargo is, to see how much the LDL and the ApoB, for that matter, associates with the outcome. You know what? This is too much of a good segue to take us right on over to the paper. At the time we're recording this, for anybody who doesn't know, the paper has not been dropped. But you, Austin, were part of the tight circle that gets to actually take a look at it. Why don't you go and tell me, the first thing you actually texted back was that you liked the title. Plaque begets plaque, but ApoB does not. Actually, just ApoB does not. What did you think of the paper? Give us your quick overview.
I loved it. I mean, and to be honest, I didn't find this is going to sound like I'm super hubris, like cocky or whatnot, but it was about what I had expected it to be. Just me personally, with my framework and the way that I kind of think about these things. But yeah, I think it's fascinating that plaque begets plaque almost in all circumstances. One of the best predictors of your risk of having a future event is not ApoB, is not LDL-C. It's not, having vascular disease trumps basically all risk factors for your risk of having another event or progression or other things like that, which just speaks to a level of frustration because we don't know everything about atherosclerosis, but it's also humbling and exciting that there's other avenues that we can still understand and still learn and figure out what this all means too. So yeah, I thought the paper was amazing. I thought it was interesting. There are a couple of things that I can't wait to dive into on and ask you some questions about. No. But by and large, shocker to everyone that is listening to this particular podcast, ApoB did not track with plaque progression. It did not track with non-calcified plaque volume. It did not track with percent atheroma volume. None of that. And the thing that did, an R squared, I think of about 0.33, was your baseline calcium, or how much calcified plaque you had at baseline. So yeah, it's a fascinating trial. And can you believe it, Dave, that, from where you started and all that you've gone through and crowdfunding something and all of the pushback that you've gotten over the years, and you finally did it, man. And again, this just, I can't speak to it enough. It just goes to show how dedicated of a human being that you are, and again, I feel like you and your team deserve a Nobel Prize. So
I naturally
figuring out the LDL receptor. Come on, Brown and Goldstein. We got Dave here now.
Naturally, a big shout out to Dr. Budoff, to Nick Norwitz, Adrian Sotomoda, Tommy Wood et al. I mean, basically, I'm so appreciative of the amount of help that I got, including the entire low carb community, helping to bring us the money to make this happen. But yeah, have you ever ran a marathon?
I haven't.
Okay.
No.
So it's a head game. Anyone will tell you that. Beyond all the training for the physical, definitely over 90% of it is just your head, just keeping you going. And I'm sure for those who are addicted to running, they get the runner's high. I've never had the runner's high. You're just kind of doing it to see if you can do it, even if you're not trying to do it competitively. And at a certain point, you're like, I just got to get to that line. I just got to do it. Even when you see it in sight, even as you're coming up there, I'm still at a little bit of disbelief that this really is, this paper we're talking about, which has not yet been released at the time we're recording this. This is it. This is a good portion of my life that I dedicate to get this. And yeah, I mean, I won't lie. Of course, I was hoping it would turn out as I was predicting, but you don't know until you're quite literally scanning it. I have to say one other thing that I have to express my sincerest thanks to all 100 of the participants, because they all showed up a second time. The researchers at Lundquist had never seen that before. They were cautioning me to not get too excited that with any study that gets, say above 10 people, it's very common for there to be abandonment of at least 15, 20%. Very common. Plus, we're not paying them. You usually have some kind of money that you're compensating. We're flying them across the country to get their first scan, and then they've got to come back a year later flying again. So I'm still blown away by just how well this whole thing was supported. But yeah, these data, it supports existing data with regard to existing plaque that exists. But on top of that, it's worth emphasizing. One key finding you can say is that we don't have any longitudinal data on healthy data sets where you can actually see that the plaque at baseline is predictive of future plaque progression. Before that was fairly diseased populations, right? So that's useful information. Now, I'll concede something before jumping onto the lipid metrics. You probably know this from listening to a lot of podcasts that I've been on. I do believe that there is some trajectory with regard to plaque formation, and that I don't think we can predict it very easily. I don't think it's clearly linear. In fact, I think some amount of calcification increase, a CAC score increasing, could ultimately be a net benefit once we finally have the dust settle and we really have some good longitudinal data as more of the non-calcified plaque gets converted to calcified. But it may well be that even non-calcified plaque progression is a slope, that it is something where it increases, but it's ultimately coming back around because it may be part of the reparative process. In the same way I would expect clotting that we can observe on the outside of a wound, right? That the
100%.
That the immune system is ultimately getting to work to deal with it. The challenge there is that you really do want to have a longer succession of scans. And I've already stated this many times before, but I'll go ahead and fit it in here now. I think I've nearly completed fundraising for a third set of scans for our participants. I don't know if we'll be able to keep all 100. It probably will have a lot of drop off because this will be for 5-year data. But we may be doing a third set of scans starting October of next year, which will have been the beginning, which will be exactly 5 years from the October 2021 beginning of scans from this study. But for now, let's talk about the data we have on hand. Yeah, the lipids, to what you said, you can kind of just state this categorically. All versions of LDL, ApoB, I mean, basically these core metrics that we're interested in, against all versions of plaque progression. There was no association. I mean, it is just a flat line there, right? That I was very curious about, but I was optimistic was going to be the case that we would not see that association. What does that say to you?
I think that it says that, there are some data to suggest that, ApoB does run some level of residual risk in individuals that have established cardiovascular disease. This is true. However, I think one of the challenges that these types of studies run into is that, ApoB is often looked at in isolation or compared to LDL-C or non-HDL-C as a metric for looking at, plaque progression on individuals that are on, let's say, like lipid-lowering therapy, for example, and secondary prevention. When you actually pin up ApoB against other metrics like remnant cholesterol or triglyceride-rich lipoprotein cholesterol or LDL triglyceride, which is like the one that I really like, guess which does a lot better? Yeah. So the latter, the ones that are more associated with maladaptive metabolism that share multicollinearity with ApoB. So again, in a healthy population that has zero remnant cholesterol, that has the milieu within their body that's not cashing out in elevated remnant cholesterol or elevated triglyceride-rich lipoprotein cholesterol or elevated LDL cholesterol or LDL triglyceride.
This is so important.
You're probably not going to see.
I really do want to break this out because, as you know, 2018, the same year that I was doing ATIA, that's when I was really obsessing about remnant cholesterol. Remnant cholesterol, the reason anybody and everybody should know, remnant cholesterol is basically ApoB-based cholesterol that's not LDL. In other words, it's not HDL cholesterol, it's not LDL cholesterol. The remainder, remnant. Another way you could put it is remnant cholesterol is the cholesterol found on lipid-rich ApoB particles, typically precursors to LDL if it came from the liver. Now, what's often going to be stated right now, if I'm trying to be steel-manning the pro-ApoB side, is going to say, but that's a small percentage of the total of ApoB lipoproteins. The majority of ApoB lipoproteins are LDL.
90 to 95%.
90 to 95%, yes. However, you probably saw my lecture from 2020, why I emphasize this so much. It's the tiniest little change in the remnant number. It's a small increase in the remnant number. Has this massive outsized effect on your associated risk. But I wouldn't say it's because they're that much more atherogenic, and I'll bet you wouldn't either. It's because what results in a higher number of triglyceride-rich ApoB lipoproteins comes back to the traffic jam. That what that's likely a part of is the same thing it's going to be clustered with, which is higher triglycerides. You mentioned it, higher LDL-TG, right? Because more of them are going to ultimately end up there through cholesterol ester transfer protein, so on and so forth. But importantly, this is also why I don't like ApoB as a metric and haven't liked it this entire time, is because it lumps together cholesterol remnants along with LDL cholesterol. So putting the remnants along with the LDL effectively ends up resulting in greater blame towards the LDL in its association with the plaque. So, okay.
The lipidologists love it.
Yeah, but and therefore, people with hypertriglyceridemia, that's going to have a marginally higher amount of ApoB due to the hypertriglyceridemia. And studies for which there's a reduction of ApoB because it actually improves metabolic health are ultimately going to get, lumped into this larger milieu, right? So I'm glad we're addressing ApoB in our paper, because if you do have high LDL cholesterol, you will have higher ApoB. But there's no other population, as you well know, that has extremely high LDL cholesterol, extremely high ApoB, low remnants.
Right.
Only lean mass hyperresponders have this. So we finally have ApoB and LDL cholesterol in isolation. And what do we see? We don't see an association between either with the progression of plaque.
There's two papers that I think are worth noting. And again, I'm not going to pretend like I'm statistical wizard like Adrian Sotomoda is. But there was one that was looking at what actually mediates cardiovascular death. And they looked at HOMA2IR, okay, which is like a version of HOMA-IR, which probably a lot of your listeners are going to be very familiar with. It's an amalgamation of two different metrics, glucose and insulin together, that kind of gives us a proxy for how insulin resistant you are. And when they looked at the in a mediation analysis, what they found out was upwards of about 75% of the cardiovascular death was attributable to HOMA2IR, when putting both remnant cholesterol and that in the model. So in other words, when remnant cholesterol is going up, it's probably not the remnant cholesterol itself that is causing the issue. Even though, you get into these like mechanistic papers, these ones have higher expression of ApoE, which doesn't require oxidation in the intima to bind to proteoglycans to recruit the macrophages, and you get the blah 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 and whatever ApoC3 is. But again, it's so much myopic focus on the lipoprotein rather than the milieu that ends up resulting in this type of condition. One of the other really interesting papers too was this paper that looked at VLDLP, which of course the higher VLDLP that you have, probably, the more remnants you have floating around, etc. And when you look at different quartiles, when VLDLP is going up and up and up, we see an increased risk of cardiovascular disease. When you take ApoB and you plot it, but you adjust it for VLDLP, the association with ApoB becomes non-significant. So what does that tell us? It tells us that it's probably not this minority component particle that is so much more atherogenic that is causing these big problems. It is probably the fact that this represents a maladaptive, inflammatory, scary milieu in the body that's conducive with the development of disease. Borge Nordeskov, famous lipidologist, does a lot of remnant cholesterol papers. And I think you retweeted this tweet that I had on one of his papers, but it was his excess ApoB paper. It's, this is where your ApoB should be predicted based on triglyceride levels. I think it was like triglycerides of like 88 or something like that, which is pretty good. It's good job, Borge. You're pretty close to that value. That seems like, at least they didn't do it at 150. But each time this sequential higher amounts of excess ApoB predicted from where your LDLP should be or your LDLC should be, they saw, again, more and more and more risk. It's a pretty small difference in the amount of ApoB that's there, but a massive difference in the risk of cardiovascular disease. Again, it's probably the milieu. But the flip side of that paper, and the thing that I think I had a couple of people kind of lose their mind on with respect to misinterpreting what I was actually writing, was excess cholesterol in ApoB was associated with a reduction in myocardial infarction, with the reduction in all-cause mortality in women. So you go to your lipidologist friend or your friend and say, hey, if your ApoB is carrying around a lot more cholesterol, do you think that's good or bad? You think it's good or bad if your ApoB is containing more of that cargo that can deposit into the arterial wall? Oh God, that's got to be way worse.
And that gets back to the ratio of ApoB, right? But non-HDL cholesterol above ApoB. In other words, ApoB containing more and more cholesterol esters is associated with lower and lower all-cause mortality.
And cardiovascular mortality.
Right. And yeah, it's
and a lot too. I mean, the effect size is big. It bifurcates at 1.4, and then once it gets above 1.4, that's when we start to see lower risk. You see a massive increased risk when your non-HDL cholesterol ratio to ApoB gets below 1.4. Not good.
And to cut to the chase, for anybody whose eyes are glazed over at this point, what we're describing is the profile that you have in your bloodstream right now. You go into LDL particles in particular. They're at the end of a chain of events based on the environment that they're in. So if you were to go to a ship right now that's out there in the sea, and you were to look at all of its prior stops, its deliveries, etc., it would be a manifest. the composition of the lipids inside of an LDL particle are a manifest. They are telling a story about how the shipping lanes are out there. And the more that it's accumulated triglycerides instead of cholesterol esters is telling us a lot about what happened in its journey before. But right now, right at this very second, Austin, I know this because you read the papers way more than I do now. They're still trying to parse out which particles are atherogenic and to what degree, which is honestly just getting harder and harder for me to read. That there really is such a genuine, active effort by very smart people to statistically determine the atherogenicity on a per particle basis, and that they can account for how much there are things like insulin resistance or statistically.
Or I mean, and again, I'm not a Mendelian randomization expert by any means. I look forward to, if you could get, not Gregor, his Twitter feed is Gregor Mendel, but who is the father of Mendelian
George
randomization?
Davy Smith?
Yes, George Davy Smith on the podcast. God, that would be an amazing episode. But it's almost even worse than the statistical modeling to try to account for insulin resistance in these contexts. They use genetic instruments and genetic perturbations that end up resulting in these different levels of remnant cholesterol to try to quantify how atherogenic on a per particle basis they are to, remnant cholesterol being 3.3 times or something like that, more atherogenic than other ApoB particles. And then you get the other lipidologists that come out, it's 90 to 95% are the LDL ApoB, so, it's useless. Who cares if it's a higher atherogenicity? And again, it misses the point entirely. And there's a massive assumption. And the assumption is that a genetic change that results in a blood level of a biometric is the same thing as what goes on throughout the lifetime of a human being that culminates in that biometric. And Adrian did a wonderful job at COSI of explaining this. I think his talk was really, really great.
Gene environment equivalency.
Right. It goes by a lot of different names: horizontal pleiotropy, exclusion restriction assumption. But the bottom line is that whatever metric you see in the blood, it doesn't matter how it really got there. The etiology is irrelevant. The cause of it is irrelevant. And it ultimately just depends on what's in the bloodstream, and there it is. And that's why you get all these fun, pretty plots on the European Atherosclerosis Society paper of all the Mendelian randomizations that look like a straight line log linear association between LDL and cardiovascular events. But there's so many exceptions to that rule.
Well, and we still have a problem. We have a problem in that if you have a disease unrelated to lipids, but it predisposes you to obesity, right? It's the fact that you become, that you're dealing with obesity will have an impact on your lipid profile. So we're back to what could easily be described as clear reverse causality if we do not have an ability to determine whether or not that's the confounder. And this is just going to be a challenge when the lipid profile is impacted by poor metabolic health, which it is. It's literally part of the criteria of metabolic syndrome. So this was always my problem with Mendelian randomizations in the first place, is unless you can, I appreciated that Siobhan helped us identify, I think it was 26 SNPs that we could find that did not associate with the change in triglycerides and HDL, only a change in LDL and or a change in LDL and total cholesterol, but not HDL or triglycerides, and were not in any way part of the pathway of lipid metabolism. It's 26 that we'd found. And I ended up using a tool called MRBase. I haven't revisited it in a while, but I was able to do a forest plot against that. Sure enough, it didn't actually associate with worse all-cause mortality. It was slightly better, in fact.
You need to publish that, because that would be, I would love to read that paper.
Well, I got lots of time.
So much time. Yeah.
Yeah.
No, exactly. But yeah, no, I think that is, that would be a clear violation. of some of the foundational assumptions of Mendelian randomization. Another of them, it's crazy to me that this doesn't, and again, maybe I'm just wrong about this stuff and maybe I'm just too dumb to understand. So, but, when you look at different genetic variants for different reasons why ApoB is high. So you'll compare genetic variants of lipoprotein lipase, which is an enzyme that's expressed in various tissues in the body that basically helps the VLDL, the big bloated triglyceride-rich cargo ship, drop off its triglycerides at its destination, hydrolyzes them. Individuals that have genetic perturbations in lipoprotein lipase can have higher ApoB. Individuals that have genetic perturbations in their LDL receptor, which is the classic, familial hypercholesterolemia type of phenomenon, when they have polymorphisms in the constellation of genes that culminate in the creation of an LDL receptor, they carry a different level of risk. So per ApoB particle count, depending on the type of genetic perturbation that gets you there, you have a different risk associated with it. Isn't that a clear violation of? And then just then we dovetail into more meta or global data with respect to no genetic etiology, polygenic etiology, or monogenic etiology with respect to FH, and the attributable risks that are associated with it. If you get a pathogenic variant that is monogenic with respect to FH, your risk is orders of magnitude larger than your counterpart that is non-genetically based, even at the exact same LDL cholesterol level.
Exactly. That's the key thing to emphasize. You've probably seen my slide that takes these three categories apart, but it's worth emphasizing this. So you've got three different groups, all with the same high LDL cholesterol levels, and yet you have different levels of cardiovascular disease risk by a substantial amount between all three. One being monogenic FH, the classic one we're used to with Brown and Goldstein, such as FH or ApoB or LDL-RAP1, for example. Then over here you've got polygenetic, which gets into the scores. We'll talk about that in a moment. And then there's no known genetic component, but they have high LDL. This group is super low risk comparatively, stepwise, up to this larger group. So there is clearly genetically some independent component with those who have monogenetic FH. That's already the point where you want to stop the music, to take a moment to try to understand where that differentiates. But on top of that, we have this other problem, which this also gets applied when we're talking pharmaceutical, which is, and I'm not going to call him out, but there's a very prominent lipidologist who themselves says it matters how you lower ApoB, but by the same token, thinks ApoB is, as he would say, the whole game, right? So I feel like you can't consistently have both positions.
How do you reconcile that?
Right.
You can't reconcile it.
If I say I have a way to lower my ApoB, and then the immediate response is, well, now wait a sec, has there been a big trial around it to confirm it's efficacious and that you really will lower events? And I'd say, you're telling me ApoB is the whole game, so it doesn't really matter how I lower it unless you can identify what it is that's compensatorily changing it by the same order of magnitude of what benefit we could expect.
Well, and to steel man their argument, they would say that, it's ApoB reduction via upregulation of LDL receptor. That's what they would say. Any mechanism by which you upregulate LDL receptors in the liver to grab more ApoB out of your pool in the bloodstream, you're going to see a proportional reduction in cardiovascular risk.
How does that interact with the response to retention hypothesis then?
There are so many challenges that I don't even know where to start.
Right. So
right.
You're already on the same page that I am. If you want to add this additional component where you're saying the receptor, where you see the greatest efficacious return on investment is in some outcome that upregulates the LDL receptor, I'm with you. I think that there actually is a plausible case to be made, but it's now a different lipid hypothesis than the one we traditionally know. You can't say it's only about what the snapshot of ApoB levels are in the blood from a blood test that signifies the level of risk you have. You're now actually identifying the method by which it's the levels it is as being super relevant. That's okay. That already is what my case is. I think what got us to those levels is relevant. Totally agree there. But now we're into something new. As you heard when I had my conversation with Ethan Weiss, I regularly point this out. I think there's a massive difference between how levels get in and if there's an impairment in synthesis and secretion of ApoB. There's a lot of bad that's associated with that, but they want to leave that off the table. Things like A-beta lipoproteinemia and familial hypo-beta lipoproteinemia. They want to keep those off, but I think they're super relevant because if you've got receptors that remove them faster, at least they still get into circulation. And I think that there is some degree of physiology that suggests there is benefit for them to at least get into circulation before we even get into the discussion of the concentration gradient. But the very straightforward concentration gradient version of the lipid hypothesis that the LDL burden or the ApoB burden can be understood from that snapshot. I would hope that we've at least advanced enough in the conversation to say, okay, if you want to bring on this receptor thing,
it's dead.
Yeah.
It's not diffusion mediated. Let me repeat.
Yes. Yes.
We have enough evidence out here that suggests that it's not. Now, that doesn't mean that if you have more ApoB particles in your bloodstream, that doesn't mean that it's not direct and proportional to transcytosis or something along those lines. But it's not diffusion mediated. So we need to.
That's the next piece.
Yeah.
Right. So how it gets in versus how it gets removed is one thing. The diffusion mediated, you already know this. I think we might have been talking before even the EAS 2020 paper came out. I don't remember for sure. But the EAS 2020 paper, same group that also did the very famous 2017 low density lipoproteins cause atherosclerotic cardiovascular disease. That was the point in which there was this acknowledgement of transcytosis being the primary means of how LDL particles get into the subintimal space. That's where transcytosis came into play. But as you know, and I harp on this quite a bit for good reason, that's an active process. And that's hugely relevant because now we can I thought at that point the lipid hypothesis would necessarily need to change because, and I think I challenged Lipofan on this. I'm not sure if you sent me any papers that you could find on it. I still have yet to find something that's stimulatory about the concentration gradient of ApoB that stimulates directly transcytosis of endothelial cells. So sorry if everyone's glossing over here. What I mean by that is there a way that we can induce more transcytosis of LDL particles by simply increasing their concentration in the bloodstream? And I don't believe there's a stimulatory effect of that concentration that I am aware of.
I think there might be some in vitro models or something along those lines, which would be like, outside the body. I think you might always run into some challenges with that too because of the fact that the phospholipids and other components in ApoB can be oxidized. And so, unless you find a way to completely prevent that and then, drive that.
They would get reduced by scavenger receptors.
Right, exactly. Right? Scavenger receptor like SRB1 and LOX1 and all. And so I wonder if that.
So let me tweak it a little bit just to keep the model straight. Non-modified LDL particles, that there would be a stimulatory effect by their concentration.
Well, I got to get through the glycocalyx. Yeah. So, and it's interesting because Lipofan and one of my other buddies on Twitter, Clint O'Menley, had a interesting discussion with the Jan Boren. And basically what that discussion, from what I had understood, culminated in is the fact that native LDL cannot damage the glycocalyx. It has to be oxidized LDL that can actually damage the glycocalyx. So yeah, great, whatever upregulates transcytosis from a particle count standpoint, fine, but you got to get it through the glycocalyx first too. And granted too, like just to play devil's advocate, there could be perturbations in human physiology all day long. Maybe the stress of me, driving over here caused my glycocalyx to wear down because I was, nervous about chatting with Dave Feldman on a podcast. And these are probably perturbances that happen all throughout the day. So I'm not going to say like, hey, my glycocalyx is just like, I mean, I guess I have no way of measuring that too, but even if I did have a way of measuring that, I would need like a continuous glycocalyx monitor in order to truly figure out the area under the curve of how well that thing is functioning. Just the bottom line is human physiology is remarkably complex.
But this is why I like to do the math on these things. The mass of the diameter of a low density lipoprotein is 22.5 nanometers, if my memory is correct. I don't have offhand, I don't know the mass of these glycocalyx, but they are like giant stalks that I like to call them fur once you understand how they function, because they're meant to kind of also keep a sort of a slick like surface. But to your point, these stalks are up here. The receptors, they protrude through the glycocalyx. But getting back to that whole penetration component, I don't believe that there is a means by which the LDL particles are causing the primary means of mechanical stress. There are things like red blood cells that are gigantic by comparison. It's not even a close call. I do think that there are other mechanisms of ways by which there can be damage to the endothelium. I just don't think that LDL particles are themselves the crashers, if you will. Now, as far as the mechanism of action that I identify regularly, the playbook of inflammation, well, yeah, there's two ways. And we know them both really well. One is that endothelial cells at a site of inflammation separate in order to activate VCAM and the chemokines and so forth to attract the monocytes in so that they can differentiate into macrophages underneath in that subintimal space. Okay, well then everything that's smaller than that can theoretically be able to come through that way. But on top of that, inflamed endothelial cells in that 2020 EAS paper upregulate greater transcytosis, the same process we're talking about that bring the LDL particles into the subintimal space. And I don't think that's an accident. I think they're part of the innate immune response. I've said this in many other podcasts, but I'll say it again here. And this is why I have such a problem with the response to retention disregarding where the response to injury is competing. They're not necessarily mutually exclusive, but the response to injury is the hypothesis that no, where you've got damage, that's where you're going to have the development of atherosclerosis. And this further supports that, including all the animal models where we do the same thing, where we damage the carotid arteries in order to create a site of inflammation on purpose that then develops into plaque. So again, to get a clean signal, we're back to ideally you're looking at vessels that are not inflamed. You're looking at vessels that aren't highly oxidized to further oxidize the ApoB lipoproteins. You're wanting to just get healthy vessels that have sky-high levels of ApoB lipoproteins. That's like the best experimental model, I think, that you can come up with.
Yep, I think it might be more aptly named, in my opinion, the response to inadequate autophagy. That's what I would like to rename them. And here's why. Because I think that amalgamates both response to retention and response to injury. But the bottom line is if this is in fact an active process, if the immune cells are brought in for a specific purpose to get rid of the damage, then I think it's the inability for that system to resolve, that issue to resolve, that ultimately results in clinical events, not atherosclerosis, okay, because it's very important to distinguish, and we should talk about that too with the paper, but it's very important to distinguish between subclinical atherosclerosis and atherosclerotic cardiovascular disease, because I think I brought this up in Tro's podcast, the Maasai have a lot of calcified plaque in their blood vessels, but the rate of events is very low. So again, it all kind of, but I think really what it boils down to is that once these macrophages come in to clean up the mess, if there's no resolution from adequate cholesterol efflux, from the anti-inflammatory components that are found in an atheroma, all of the other components that go into it, then yeah, you're going to be in trouble. But if there is all of those components that are incorporated within that framework, within that pathogenesis, then it's probably just going to be like a big old scar that you got when you fell off your skateboard. Is a scar a bad thing? I mean, maybe cosmetically it doesn't look great. Might make you pick up a couple extra chicks. But by and large, is it gonna actually result in some clinically relevant disease or change in quality of life? I don't know. Probably not.
I mean, if your whole body was a scar, then yeah, you can't. You
can't move.
You can't, and your skin can't breathe.
Right.
Okay. But yeah, trade-offs, right? So your body's making a trade-off of, well, I can't do efferocytosis to fully repair the tissue that's here, but I'm not going to leave the wound open and just let the blood continue out. So here's this process that gets us a nice in-between. It's a scar. Fair enough. Do I think that's what's going on in the vasculature? Of course I do. Of course I this is part of my frustration with not being able to discuss these things, I think, in a rational manner. To say, for example, that I believe some degree of what we perceive to be a positive feedback loop of indefinite atherosclerosis growth, atherogenesis, some amount of it is hemodynamics. What do I want to say? Hemostasis. It's hemostasis. So there's primary hemostasis, there's secondary hemostasis, both of which are well studied. And then way over here at the other end of the spectrum is calcification. Somewhere in between there is this process of atheroma that I think up to a certain threshold can be controlled and possibly cleaned up and possibly cleared out.
Probably happens all the time, to be honest.
Exactly. Probably happens all the time. And that's why I like that you brought up apoptosis, because I'll bet that a lot of it's happening around apoptosis in particular. Endothelial cells have to apoptose just like all the rest of these nucleated cells.
Right.
And in the process of that happening, one of the cool things is these macrophages, I mean, they're one of my favorite cells in the body. But they've got to be able to accomplish their work. And bringing blood pressure back into the fold. Blood pressure is terrible for the immune response because they're counting on closing hours to get their work done. They're counting on the store to be closed. They're counting on the traffic to die down. And I think that's very relevant for things like vascular repair. But I've never believed that macrophages just come into the subintimal space. They see this modified cholesterol, this lipoprotein. They gobble it up and they're like, I just have to stay here. I'm just going to relax.
Die.
Exactly. I'm going to become necrotic. Other macrophages are going to come to me, but they also just lose their way. They can't. No, macrophages are fast. They're mobile. They are constantly picking up debris and then moving it. That's their job. There's a reason they look like Pac-Man when we, draw them out, because it's macro, big, phage, eat. They're big eaters. And you ever watch those not animations, but they're like time lapse. That's what I want to say, where you can actually see how they're moving around to grab pathogens.
Yeah, they're amazing.
They're amazing.
Those are so cool.
Yeah, exactly. So I've always had a tough time with this hypothesis that this thing happens and then nothing can be done, and it just will necessarily continue to grow indefinitely.
Well, and I think to Steelman, the other side of the position, I mean, there are studies that have been published that look at, your size of your plaque over time. Like there's one study that an individual on Twitter sent me, and it looks like, it goes up and down and up and down and up and down. So there are, well-documented cases of progression and regression. And this happens. So I think that's kind of case closed. The question is whether or not it keeps going up and up and up in that trajectory, rather than going, okay, up and then back down and then stay stable and then goes up and then back down and stay stable. Because I think, unfortunately, in an unhealthy population that has a background of maladaptive metabolism, inflammation, etc., you're going to see that probably insidious rise, regression and then progression and then but it's going to end up cashing out in, a larger global atheroma volume than a healthier population per se, which kind of dovetails into the lean mass hyperresponder that keto CTA study is I think it's important to make that distinction between, what is subclinical atherosclerosis and what is actual disease. Now, here's the thing, and this is just me being candid. As a clinician, as an individual that has someone's life, in front of them and whatnot, I am not looking to play Russian roulette. We can have academic discussions all we want about, these people that saw some plaque progression on that. Maybe they had an infection where the LDL is quarantining some LPS or whatever, something along those lines that's cashing out on a change in their CTA during this point in time. But, I think me as a clinician too, and I think even the vast majority of people, even in the low carb community, would say like, if you have some level of plaque in your blood vessels, calcified or not, we probably want to try to use tools to mitigate that. And again, you might disagree with that, and other people might disagree with that. But I'm kind of like
coming out of my mouth.
If your calcium score is 0, I feel at least about a short-term risk pretty darn good. If your calcium score is north of 0, then again, I'm not looking to play Russian roulette. We're throwing the kitchen sink of it at you, focusing on your lifestyle modifications and your maladaptive metabolism first. We should also, I know we're kind of like flying all over the place, transcytosis and then this and then that, but we should talk about the power of 0 too. And I think what that entails as far as our understanding of the drivers of heart disease.
And by power of 0, you're referring to when somebody gets a coronary artery calcification scan, often called CAC or CAC, they get a calcification score, the Agatston score of 0, meaning no detectable calcified plaque on the scan.
Right, exactly. And I think you hear a lot of individuals say things like ApoB is the cause of heart disease, or LDL is the cause of heart disease. And I think me and you and most people that are, I think, reasonable would suggest that ApoB plays a role in the atherosclerotic process. There's no doubt about that. It is a necessary component in the process of atherosclerosis as we know it. Whether or not it's the cause of it is a very strange question. Sorry, I didn't mean to interrupt. Go ahead.
No. I was just gonna. Usually, what I'm doing, as you know, usually when I'm saying this and I'm acknowledging it's part of the causal path, I'm either going straight into, as are macrophages, to draw attention to there are these various components, and we just talked about macrophages, or I use my analogy where I'm saying, but so too are car tires to car accidents. They're part of the causal pathway.
Right.
And I'm not doing that to then kind of reintroduce doubt per se, but just to try to get the conversation to be more intelligent than stopping the discussion right there. Okay, so then we're clear, right? It's part of the causal pathway. I'm not even sure why we're talking any longer. You're now acknowledging that it's this piece of it. And that's part of my problem with having these conversations is I think you're wanting to do the same thing right now. You're wanting to say there are any number of different ways in which there may be interventions related to changing ApoB levels in the blood that relate back to this causal pathway aspect that could be a benefit for given populations. And I want to keep that on the table. I don't want to put words in your mouth, but I'm guessing that might be one thing you could say, while also acknowledging that the opposite, that there's some number of populations we can't speak to that may not be benefiting at all by changing these numbers, even if we're saying that there is an acknowledgement that there's the causal pathway connection.
Right.
Right. How is that possible? Well, it gets possible when you start thinking about it in this nuance. But you've got to do that first. We can't oversimplify this.
Well, and you could make it a very intuitive example with macrophages. I mean, of course, if you get rid of macrophages, you're not going to have as much atherosclerosis. Exactly. You're also going to probably die from an infection.
Exactly.
So, yeah, I mean, that type of reductionist. Causal is a weird word in biology, I think. It gets thrown around in a sense that, the cause or primary cause or contributing cause or whatever. And
That's
I
why
think,
I like driver.
Yeah, I think it just
the independent driver of or central driver.
Yeah, and that kind of language just it kind of like bogs me down a little bit. But here's I think some very interesting and reasonable inferences that we can make from, because I think the calcium scoring in general has just been a blessing for us understanding cardiovascular disease. from a risk factor standpoint in particular, because, we're at a point in time where we can detect disease very early on in the process and determine what factors contribute the most and what factors don't contribute as much. And there's a couple things that I think are really interesting observations. Number one, in individuals that have a calcium score of 0, there are a set of metrics that track with future events, okay? We're not talking subclinical atherosclerosis. We're talking about people getting a major adverse cardiac event, like a myocardial infarction or a stroke or something along those lines. Well, we know from Western Denmark Registry, which I know you love that trial.
Love it.
So it's a fantastic, super interesting paper. But what we know from that trial is there was basically 3 things that were strongly identified. One of which was shocker diabetes is associated with future events in individuals that have a calcium score of 0. Number 2 was smoking, current smoker. And then number 3 in that paper was low HDL cholesterol, which of course is a proxy for insulin resistance. Now I'm going to put a pin in that for a second. So then they took this data and they ended up kind of trying to cross-reference it with MESA. MESA is the multi-ethnic study of atherosclerosis. And in that study, they had 16.6 years of follow-up. And they basically confirmed all of the specific metrics that were in Western Denmark Registry with a broader cohort that they looked at. What they found out in that cohort too, along with Western Denmark Registry, was that LDL cholesterol did not associate with future events in individuals that have a calcium score of 0. Okay? I don't know how the thing that is the cause of heart disease only is the cause when disease is present. Because if disease is not present, based on pretty decent follow-up, high-quality data, it would suggest that at least over 4.3 years of follow-up from Western Denmark Registry, if your LDL is north of 193 or below 116, no difference in MACE, no difference in MI. So, I think as the drivers of heart disease, I think are the primary cause or the cause, you would think that the cause would be something that would be associated with events in individuals that don't have any disease, and it's not. And okay, so let me make a quick little steelman argument here. Low HDLC by the lipidologists of the world say that low HDLC is just a proxy for high ApoB. That's what they'll say. Because you have high triglycerides, you have low HDL cholesterol. We already talked about this before. That's a physiological milieu that's conducive with a higher amount of LDL particles. But when you look at individuals with a calcium score of 0 and you stratify them into tertiles, which are 3 separate groups. I think this was quartiles with Crom-Nassir's work. In individuals that have a calcium score of 0, whether you had super low LDL particle count or super high LDL particle count, the difference in a number of events per 1,000 person years of follow-up was like 1. So in other words, you're at the lowest count and you're at like 2.3 per 1,000 years of follow-up. And then if you're at the highest count, you're at 3.3. But if you're at the lowest count, but your calcium score is above 100, it's like 17 events per 1,000 person years of follow-up. So again, if you're picking between the two or looking at what's the more predictive metric, calcified plaque all the way. And so I think low HDLC in this context is probably not a proxy for elevated ApoB or high particle count. I think it's a proxy for what we've been talking about this entire time, which is that maladaptive, metabolic, inflammatory milieu. So again, as far as the drivers of, or primary driver or drivers of heart disease, hypertension, smoking, diabetes, low HDL cholesterol. So as long as you don't smoke, keep your metabolic house in order, and you're very unlikely to have an event if you have a calcium score of 0, at least over a short-term follow-up. So that's kind of how I think about that. What are your thoughts on that?
Well, of course I can try to steelman the other side, which is they're going to say it's a late-stage disease. And I think they would also say, well, wait a sec, because we know that it's late-stage disease for calcification, there's just not been enough time exposure to the LDL to where it could have induced events. Right.
17 years is a pretty long time, but yeah, go ahead.
And there are, and I've quite quite seen it, for example, with our study. Well, it takes decades. It takes decades for the LDL to actually have the level of deposition for which it's going to create atherosclerosis. I'm actually happy to be finally chatting with you about this because we have chatted about this a lot privately in our DMs. I will concede this has been something I was surprised is brought up as prominently as it has been by many of the same folks who tout studies like PESA, which we should be chatting about also.
Yes, pin in that
one. Where I think I even had a spreadsheet. I didn't bring it to the podcast, but I worked it up from last night. I wanted every prominent study. I asked ChatGPT to give me the top 25 most influential trials with regard to cholesterol lowering. And I wanted to give me both the relative reduction in LDL cholesterol and the absolute, and also the years taken. And yeah, a lot of them, I think the average years was something in the neighborhood of, I want to say 2.5 or 3, something like that. Some went as much as 5 years. But as you know, our cohort in the lean mass hyperresponder study in keto CTA, the average years, by the end, I actually have it here on the table, but it's half a decade. So given the amount of time that we've got and the threshold of high LDL, the exposure is quite substantial. But moreover, when you look at these randomized control trials, the intervention group, the change in LDL cholesterol in lowering, I don't think any of them come anywhere close to how much we have a change of increase in our study participants. Therefore, you would expect there to be a signal that would be shown, unless the argument is that a change in LDL cholesterol is not expected to have any effect on plaque itself, as would be picked up by a CT angiogram, but would have an effect on events.
Which I think is a tough.
This would be an entirely new hypothesis that I've never heard of before. But again, you cannot hold both positions at the same time and be consistent. You can't say the existing, for example, 2017 EAS meta-analysis that says low-density lipoproteins cause atherosclerosis that lean in on these same randomized control trials that are the same amount of time or less than how long our group has been on a ketogenic diet at baseline as well as with the 1 year. And then also discount our data as being too short and that it takes decades. And therefore, the critics won't be around anymore for us to actually be able to examine if there's been a change. How long does it take a change in LDL to affect plaque? That should be the starting question for anybody who's examining these data and has both those opinions. If the answer is with these studies that have a drug intervention, it's however long the study was to see that statistically significant change, then we would expect to see that in our group as well.
Mm-hmm. I agree. I mean, and it's just, and we don't, right? And so I think this is just one of my other irritations is just the way that data is presented, the way that data is manipulated, the way that data is, depending on what statistical model you use and all those other things, that you could get, very, very different answers, and it all just makes it really confusing. I think there's a couple of studies that look at like baseline LDL and how that tracks with events in statin trials versus the absolute reduction in LDL that you see with lipid-lowering therapy. Baseline LDL has nothing to do with the rate of events at all. It's all about the nominal reduction of LDL cholesterol. And then you look at Silverman's meta-analysis with all these different, which I'm sure you've seen that meta-analysis before, but it's the one that's got PCSK9 inhibitors on it and statins and diet and all these different things, and they do this meta-regression. And everything falls on this beautiful line downward. For every 1 millimole per liter of LDL cholesterol lowering you get about a 25% reduction in cardiovascular events over a 5-year period. The R squared on that line was like 0.98, meaning that 98% of the variance in a reduction in cardiovascular events is attributable to LDL cholesterol. Now, the technophiles that are listening to this podcast, I might be wrong about that because I'm not a biostatistician or anything like that. But 98% of the reason why these drugs work is because they're reducing LDL cholesterol via upregulating LDL receptor. Fast forward to like 3 weeks ago, there was another analysis that was published by a different group that looked at just statin trials. And they sought, by a much more stringent criteria than Silverman did, about elucidating what was the variance explained by LDL cholesterol reduction, specifically in statin trials. Their R-squared was like 0.1, okay? So that means 10% of the effect size that you would see, of the variance that you would see with respect to heart disease reduction, was attributable to LDL cholesterol in statin trials. How do you reconcile those two data? How do you say in one meta-analysis that it's perfect and it's just all about LDL cholesterol with all these different medicines, and then in this other meta-analysis that looks at statins, it basically has zero correlation? So that's where I think what this ends up being is more of this broader overarching point, which just suggests that the way that an individual wants to present data and put it into their statistical modeling tool can really lend itself to a lot of inconsistencies and make it really, really hard as a clinician to navigate through and to be able to provide a comfortable level of evidence to a patient.
I'll capitalize on this and make a plausible case for statins. Not that I'm trying to, more to capitalize on your statement. Let's say that statins actually achieve a benefit via pleiotropy. In other words, how they're lowering LDL isn't actually their primary means of efficacious capability, especially in secondary prevention. So somebody has a heart attack, they're taking statins, they see improvement. And one of the ways by which you can see a statin's effect is in the lowering of the LDL cholesterol. But let's say it's the anti-inflammatory component, which many people bring up, right? That would explain exactly what you just now described, that what degree statistically could be quarantined as to the LDL cholesterol change turned out to not have as much of a correlation with the benefit. But the use of the statin itself in those trials still suggested a benefit. Well, this would be in line with what the big lipidologist was that I was speaking to earlier, which is how you lowered LDL cholesterol did turn out to matter as to whether or not you'd see a benefit. And heck, right now I'm giving a plausible case for statins in particular, right? And why other things, which I know you know many of them, that result in lowering LDL do not have a likewise result in reduction of cardiovascular disease. And there should be nothing wrong with that. To be able to say, hey, we may not actually know why a given intervention X is beneficial for outcome Y. Let's go ahead and just acknowledge that it seems to be this data might seem to have this benefit if you're a clinician and that's what you need to operate from, right? Now, again, this is not me somehow working in some version of medical advice, but ironically, I'm almost trying to throw a bone to those who might be saying, hey, I can't help it. I've staked so much of our mutual reputation on this particular metric of interest that all battles need to be fought through that lens. That you may, in fact, be reducing the capability, or the likelihood of certain people taking that intervention that might, in fact, be benefiting from it if there is a benefit. That's what's so crazy about this. David Diamond likes to point to that reanalysis of 4S that shows, sure enough, when you stratify for those people who have very low HDL, or I call it very low if you're below 40. I think it's below 40 and triglycerides above 150, that there's more efficaciousness to the to taking the statin. I forgot what the statin was for 4S.
Simvastatin.
Simvastatin, yeah. And that there was less the more metabolically healthy you were, such that it was negligible. I don't remember exactly what it was.
Oh, it was an overlapping line. So that
basically an overlapping
there's
line.
no difference. Yeah.
Right. So at least within that trial, and that was secondary prevention.
Right.
The placebo group fared about the same as the intervention group when both were metabolically healthy, when you stratified by metabolic health for both. right?
Yep.
And therefore, you could be making the case as a clinician, look, if you're not going to take steps to improve your metabolic health, and I think David Diamond himself has said this, you actually have a strong case, if you're looking at this data in this case, to consider statin therapy.
Yeah.
Right?
Yeah. And again, I'll play devil's advocate again. Devil's advocate back and forth. But, I think post hoc analyses are tough, because they're subjected to data mining and data dredging and all sorts of fun stuff. We could talk about PESA soon.
I know that's right where we're going to head next.
But if you look at I'll give you an example, with the field trial with fenofibrate. For the longest time, the lipid community thought that fenofibrate resulted in a demonstrable reduction in major cardiac events in individuals that were either diabetic or non-diabetic with triglycerides north of 150 and HDL below 40. So, in that phenotype, if you add a statin, or if you have your statin plus your fenofibrate, you're going to see another, nominal reduction in cardiovascular events. But when we actually looked at that type of subset of patients and created an inclusion-exclusion criteria, it's called the prominent trial with pemafibrate, we found out that the lines overlapped. There was no benefit whatsoever. So that gives me, with examples like 4S, post hoc analysis, it gives me a little bit of pause of drawing a lot of strong inferences from that kind of data. The other thing too that confounds that kind of data just a little bit too is that high HDLC is also a modest proxy for hyperabsorbers of cholesterol, which is kind of interesting. And that was a little nugget that I pulled from one of Tom Dayspring's lectures or whatnot. And I haven't really looked into it that much. But here's what's fascinating about 4S, since you brought it up. And I'm a pharmacist, so it's in my wheelhouse to talk about drugs.
It was considered by the AIs the most influential of these studies. And I think that's probably accurate.
It is. And it saw the most reduction in events, saw the most reduction in mortality. And it's never been re-adjudicated, and no one's ever looked at that data independently, and it's a challenge. But having that said, these patients that were in 4S were FH train wrecks, smoking, and a lot of them had diabetes, and a lot of them had really high triglycerides. They were just absolute nightmares. But what they found out in that clinical trial, again, post hoc, was they measured their phytosterol levels in their bloodstream and their cholesterol synthesis metrics in their bloodstream. And what they found out was individuals that were hyperabsorbers, that could be proxied by high HDLC, actually saw a non-significant 16% increased risk in major adverse cardiac events in that trial. So the statin trial that has the largest magnitude of benefit that any statin trial has ever seen, individuals that were hyperabsorbers in that trial per a subgroup post-hoc analysis actually had a non-significant higher risk. So if anything, it was not beneficial, but with adequate power or whatnot, 16% higher risk of MACE. So that just gives me a lot of pause. It's also a reason why I think certain lipidologists really like to push forward with cholesterol absorption markers in certain circumstances, because if you find that you are a hyperabsorber, they may recommend ezetimibe as a first-line treatment rather than a statin. And I don't know if it's based on that specific data or not. I've never confirmed that. But bottom line is that, I don't know, post-hoc analyses are tough, and there's definitely a heterogeneity with respect to statin response.
Okay, PESA. So this is brought up frequently, particularly in cases like comparisons with our study, because we're looking at specifically people who have low atherosclerotic cardiovascular disease risk with our study, as well as being metabolically healthy. And PESA is easily the most common study that it gets compared with, because that's considered to be a low risk group. And there's this graph I've seen so many times. It's these bars that kind of line up that suggest how much detectable plaque there was, and the higher the LDL, the more there was detectable plaque. They were using, if I'm not mistaken, VUS. It's not IVUS, but it's a vascular ultrasound. But not, if I'm not mistaken, it's not cardiac. It's actually like in the carotids and
They did carotid, iliofemoral, as well as aortic
Okay.
ultrasounds.
Okay.
Yeah.
So yeah, but it's
Yeah.
ultrasound based.
Ultrasound based, yep.
And part of the reasoning for that is because then they could do more repeated tests without
Right.
as much radiation exposure like you'd see with the CT angiogram, things like that.
As well as potentially picking up on soft plaque. But yeah, go ahead.
So with that setup, do you agree with its findings that the higher LDL, the more that there was development of detectable plaque?
So I'm going to first start off by saying that, like, you know, this is me wanting to be a critical thinker and just think through this. So like I could accept, you know, these data at face value and, you know, say that like, yeah, LDL is associated with subclinical atherosclerosis in individuals that are very, very healthy. Like this cohort ultimately concluded, the authors of this cohort paper ultimately concluded. So I'm going to take a step back, and I feel like it's like what I want to do is just outline where I think that there's a lot of limitations to this paper, and where I think that sometimes I think it's great to have humility with respect to the way that you interpret things and looking at the body of evidence and all things like that. So let me just preface with saying that at the beginning. So with PESA, there's a couple of things that bug me quite a bit, and this is probably going to drive you nuts, but as far as I can tell, there's no pre-registered methodology in that paper. Okay, as far as how they ended up looking at these data and coming to their conclusions. I think this is a huge problem in all observational data sets. In fact, Miguel Hernan, who wrote the book What If? Causal Inference, who Adrian Sotomoto likes to cite quite a bit, but he's a very influential epidemiologist and kind of like a philosopher in the realm of causal inference. He is like, yeah, you know, whenever we do an observational data type of analysis, we need to be pre-specifying how we're going to get there. Otherwise, you run into these issues with p-hacking and other data dredging where you can keep slicing and dicing the data in order to get the response that you desire. So within this study, they use a methodology called stepwise regression, which is a specific statistical instrument to try to determine which variable is the best predictor variable for some sort of outcome. You know, in this case, subclinical atherosclerosis. So again, I'm not a statistical wizard or anything like that, like a lot of the people that I chat with. But what I do know is that, you know, this is a methodology that can lend itself to a little bit of statistical wizardry, by which how you put in each one of these variables into the model and put them out of the model, it can lead to spurious correlations. Again, let's just take it at face value though, and just say like, that's okay. When you look at the data with respect to how PESA and the outcomes that they were associated with it, maybe let's take a step back and just say what was associated with the outcome of this paper was. Basically, there's this graph that I've been sent probably more than the EAS paper graph that has the 3 lines on it that everybody throws around a bazillion times a day. But this graph has, you know, people that have low LDL cholesterol. I think the starting point is like 50 to 60, and then it goes all the way up to like, I don't know, 160 or something like that. So it's broken up by tens, I think, all the way up. And then basically what it shows is that, you know, as you go up and up and up in LDL cholesterol, there's a higher burden of subclinical atherosclerosis. You know, the problem with that graph right off the bat is statistical power at the lower end of the spectrum. When you look at the number of people that had an LDL cholesterol of 50 to 60, it was 2. And the number of people in that cohort that had an LDL cholesterol of 60 to 70, I think it was 9. So there's not nearly enough people in that bundle to draw some reasonable conclusions about what is the incidence of subclinical atherosclerosis within that specific cohort. Yeah, you can see it there on the screen. So yeah, N of 2 and N of 9 there. So very, very small N values for this lower end of the distribution. And then as you go up, you know, the numbers get larger, you know, 233, 275, 261. So when you actually, what's fascinating is when you actually investigate in a broader population what this looks like. And Khram Nassir had this beautiful paper that he published not too terribly long ago looking at Miami heart cohort, what they found out was 1 in 12 individuals with an LDL cholesterol below 70 had a calcium score above 100. Okay? 1 in 12. That's a lot. That's a considerable number of people. And these are all people that had LDL cholesterol, presumably lifelong, below 70. And this is a statin-free cohort, so there's no confounding in that regard. So like that is wild to me that someone could have that burden of atherosclerosis and someone would still say, well, as long as your LDL cholesterol is low, it doesn't matter, or you're not going to get heart disease or something along those lines.
Which is the thing we hear constantly.
Over and over again.
Over and on. Because I'm not sure if I'm going to have this graph in the edit. I'll just mention this is the PESA graph. I've seen this graph many times over. I'm sure you have is this. What's fascinating about this graph that we're seeing that does break up these different bars is that the bars are of the same height, suggesting it's broken up into these, what is it, 10? You're right. I think it's like 10% each.
Mm-hmm.
Seems to suggest that they're quantiles, as in there's an even distribution of 10% of the population, then another 10%, but that's not actually true. That first bar that has no atherosclerosis is an N of 2, whereas like the next bar to the right of it is an N of 9. Yet the bar height is the same, which is a little unintuitive at a minimum. But the one after that is an N of 41, right? So it's as visualization of data go, this I feel is a little bit awkward at a minimum.
Yeah, it's awkward, and it lends the reader to, it paints a picture of what the authors intended to paint, which is that, even if you're metabolically healthy, we need to lower your LDL cholesterol because there's still a burden of subclinical atherosclerosis in healthy individuals, and our current paradigm of where LDL should be is still too high or something along those lines. And granted, it could be, by the way. I'm okay with accepting that. It's just what I do care about is how it's presented and how this lends itself to an interpretation that I think is, overstated. Likewise, too, when you look at this exact cohort, they did individuals that were cardiovascular risk factor free as well as optimal cardiovascular risk factor group. Okay, so the cardiovascular risk factor free group, their inclusion criteria was like systolic blood pressure less than 140, and A1C less than 5.7%, triglycerides below 150. Maybe they didn't have triglyceride metric, HDL above 40 or something along those lines. So, I think me and you might agree that LDL is probably more likely to track with risk in metabolically unhealthy individuals. So when you look at, and not because of the LDL cholesterol maybe in and of itself, but because of what it represents as far as the milieu goes. And so even in the cardiovascular risk-free cohort of this subgroup analysis, it's still like our standards for what's healthy are so bad. They're so pathetically poor. And the challenge is that genetic loads the gun and environment pulls the trigger. And some people that have systolic blood pressure at 130 might not experience any sort of long-term complications from that. There are some people that, are going to and are going to feel it bad. In other words, MIs earlier in life, very early in life. So I don't even think that I would even like to a degree acknowledge the cardiovascular risk factor free profile, because it doesn't really look at an optimal type of individual, which is where we would want to be questioning the direct role of a clinically relevant level of LDL cholesterol. So when you look at the optimal cardiovascular risk factor group, so they then parse this down by less than 120 for blood pressure and normal A1C and all these metrics that look probably good by me and your standards. Okay, so within that cohort, they still saw with the stepwise regression analysis about a 16% increased risk of subclinical atherosclerosis per 10 milligrams of deciliter increase in LDL cholesterol. Okay, so without using a lot of numbers and stuff like that, bottom line is LDL was still associated with subclinical atherosclerosis in the optimal cardiovascular risk factor group.
But if I remember correctly, when I was looking at this originally, we also saw the change, for example, in triglycerides and I think also in HDL with those that had the higher levels of atherosclerosis. Now, it may sound as though I'm really trying to pull in HDL and triglyceride to be a part of the conversation for the purposes of suggesting they're the real cause. But as you know, no, the real reason I'm bringing this in is, are we really looking at the shadow? LDL-C is the shadow of what is a marginally worse metabolic profile in those that have the higher LDL cholesterol, because that's highly relevant to this question, right? When we're looking at these associations. And it shouldn't even be something that has to get discussed at all if all we're ever doing is we're seeing this strata play out over and over again, because then that association makes sense, for the same reason that I would feel that way if blood pressure going up along with these changes in lipids seem to be reflective in this cluster. And this, the part of why you brought this up was the statistical aspect. There's a lot to be critical of, frankly, of the statistical approach, in my opinion, with PESA. But, and this, by the way, goes with the lie. I think, if I'm not mistaken, there's been several analyses with PESA, but the one I saw that kind of, I was in the middle of highlighting and I just stopped highlighting and then stepped away from the paper, was the paper that I was looking at that had done an analysis from this cohort, had adjusted for triglycerides and HDL, but wasn't specific on it. The commonality that I find is whatever their adjustment is that they counter each other. They go, oh, well, to the degree with which their HDL was low and their triglycerides were high, people who have low HDL tend to have high triglycerides and vice versa. It's as though they can cancel each other out comfortably, to know that that's not the nature of the problem. Anyway, I digress. My larger point is, if the reason for the higher LDL cholesterol itself comes back to insulin resistance syndrome, we have to know that to make a clear-eyed accounting of its independent driver of plaque development.
Right.
We have to. We can't keep chasing our tail on this. And it's why I feel like, apart from my involvement, I feel keto may have given us one of the best scientific gifts in the lean mass hyperresponder phenotype. We just needed to, if there's a single thing I reflect on often that I go, for everything that's happened, this was probably one of the best moves that I can point to. It was identifying a phenotype that combined all three of these, that combined the triad, and then giving it a name, and then that being a way by which we can then point our lens at this. It's why I think you watched it in real time. It's why I think a few years ago there ended up being almost a campaign to try to take it back out of the lexicon. For a while, the same people I was discussing the lean mass hyperresponder phenotype, people who were genuinely interested and excited to discuss it, but who were pro-lipid hypothesis, seemingly all at once wanted to just pretend the term itself didn't exist, that it's like made up, even though all it is a description, right?
And every term is made up.
Right, exactly.
I mean, like where do you think these terms come from? They're not given on high by some, medical authority that says like this is what this is, and it's just it's a level of frustration too with an interview I think that you had with Ethan Weiss, where he was just like, Dave, as far as I'm concerned, you just made it up. Who do you think made up PCOS? Who do you think made up metabolic syndrome? Like, it's the same exact process.
My favorite, atherogenic dyslipidemia. Where's the marker for atherogenesis? In that it's a profile.
So not only is it irrelevant to pull in the fact that lean mass doesn't necessarily have to be a component within whatever you're describing, because cysts don't have to be in PCOS, and atherogenesis doesn't have to be in atherogenic dyslipidemia. But like, everybody has to create a name or a word for something, and yeah, you made it up, but that's what everybody does. It's just kind of silly.
And heck, you could call it a new name.
Yeah.
I'd be fine with that. The reason why I think this turned out to be such a significant move was probably for the reason why I think a lot of critics don't like it, is because it bundles in the metabolic health component in the same lipid profile you already have. You have this lipid panel anyway. And now you have this proxy for metabolic health that can at least help us look at high LDL in that context. And I think it's really helped to codify this and better isolate this so that the one thing I wasn't predicting for sure is I thought as we got further along with the lean mass hyperresponder research that there would at least be more of an interest out there for others to take this very seriously and develop studies of their own, prospective studies. Now, as you probably saw, one of my predictions for this year is I think actually it's going to be the other direction. I think there's going to be more retrospective. I think there's going to be more case series, which unfortunately allow you to cherry pick whatever you want,
right,
from a large pool, from a sizable population to meet whatever narrative, which is unfortunate. I'd like more prospective data. So whatever, I guess we'll do our own, just where the triad study comes in.
Well, I'm excited for that, for sure. We'll just put a couple quick pins in PESA, and then we can move on because I might need to take a little bathroom break. But as far as PESA goes, the individuals that had optimal cardiovascular risk factors, 94% of them had a calcium score of 0. From MESA, what we know is that over 16.6 years of follow-up, LDL cholesterol doesn't appear to associate with events. Okay, so again, differentiation between subclinical atherosclerosis and atherosclerotic cardiovascular disease. Okay, when it comes to the things that matter, which are the actual events, the LDL cholesterol appears in 94% of these optimal cardiovascular risk factors. It appears to not associate with events. Maybe with a little bit of subclinical atherosclerosis, but not with events. And again, that kind of harkens back to what you were talking about earlier. Progression, regression. Just like a scar, just like a cut on the body. And you might have a cut right there one day. Later, you don't have a cut. You have a scar.
You share my prediction.
Yep, exactly. And then the other 6%, none of them had a calcium score over 100 too. So this is a remarkably, low burden that predicts future events too. And the question somewhat remains too is, for this cohort, how much benefit are they going to see from, primordial prevention in that case? Like because we know individuals that have a calcium score of 0, you have to treat 3,571 of them in order to prevent one major adverse cardiac event over 10 years. That's abysmally low.
And just to level set for people, when we're saying, you and I are familiar with the term primordial prevention. This is the concept of you could get your LDL so low, it's typical of a child at super young age that's actually rapidly growing. Their LDL is down there, you probably know. Is it in the 50s or something like that?
Well, depending on what data set you look at. I mean, actually, I think it's 8 months of life or maybe 18 months of life. ApoB is 80. So, or 73, I think was the mean.
So it's not even that low. And you're
but
talking
I think
ApoB,
neonate, yeah, 20 to 40, I think, LDL
right.
cholesterol.
And you already know my theory on this.
Yeah.
I think it's not low because there quite literally is just less production and less that's entering circulation. I just think more is leaving circulation. Again, because I believe in the structural hypothesis, which...
I mean, it's a growing baby.
Exactly.
So,
that's just my thought.
People just forget, and again, this is just a beautiful engineer trait. People forget about dynamism with respect to systems.
Right.
You can't infer the rate of production and clearance from a blood level. You can't do it. So you can, kind of hypothesize about it or whatnot, but unless you have an exotic tracer that can look at how quickly producing and how quickly clearing, as far as I understand, again, this is just from my feeble pharmacist mind, you can't infer anything about that. So saying a very young child, by the way, young children may have blood glucose values of 30. I don't think that that's a great thing to strive for. You'd probably be dead. Unless, of course, you're in one of, Cahill's study where they starved you for a long, long time, and then, you got your ketone levels giving about 70% of your energy to the brain.
So I interrupted you you were making a key point, and I just wanted to let everyone know what you meant by primordial. Even for those folks who get down to primordial prevention, how many do we have to treat to see a benefit?
Yeah, so for individuals that have a calcium score of 0, you have to treat 3,571 patients over 10 years to prevent one major adverse cardiac event.
So not even death specifically.
Not even death.
MACE, which can also include it's a composite endpoint.
Yes, there's a lot of subjective Like there's coronary revascularization that's oftentimes coupled in harder endpoints like MI and myocardial infarction and stroke and non-fatal stroke in particular and things like that. So yeah, a lot of people. But even in that other 6%, as far as I know, the best data that we have would say that like the number needed to treat over 10 years is about 100. Meaning that you have to treat 100 people with a statin medication in order to prevent one major adverse cardiac event. So if you actually just kind of run through, okay, what's the event rate in individuals that have a calcium score of between 1 and 100? What we find from MESA, depending on the age of the population, I think it's anywhere between like 3 and 8 events per 1,000 person years of follow-up. Let's just say 5, okay? So we'll just make it in the middle. So that means that if you take 100 patients and treat them all with a statin for 10 years, that out of all 5 of those people that may have had an event or not, 4 of them will still go on to have an event. And then you've prevented 1 out of those 5 people of having a major adverse cardiac event. 95% of them saw no benefit over a 10-year period, 95 out of 100. So you're still looking at a relatively modest benefit that's going on here.
And this is for people with calcium score of 1 to 100. They don't even have a 0.
They don't even have a 0.
Yeah.
Yep. So even for that other 6%. And then finally, just to kind of, there's a couple of other points on PESA that I think are important. Cromness here did a study that was just like this, same type of cohort. No significant association with LDL cholesterol and events, or in subclinical atherosclerosis. And then likewise too, when you use machine learning modeling in looking at all the different metrics and how they ultimately cash out to the risk of cardiovascular disease, LDL doesn't even make the top 5. So again, I think what this just lends itself to is a lot of it's science in a sense that they're not trying to disprove themselves, which is what good scientists do. They generate a hypothesis and they try to disprove their hypothesis, not confirm it. And I think, again, it harkens back to this analogy that we've made 1,000 times, which is, trying to jam a square peg into a round hole. And that's what I think it sometimes ultimately results in too. So not only is it challenging to say that LDL cholesterol has, association with subclinical atherosclerosis, not even events, in individuals that are metabolically healthy. But the question also remains too is, what are you going to do about it? Because, there's not a lot of data to suggest that lowering your LDL cholesterol is going to actually cash out in, a remarkable benefit for that cohort anyways. So it all just ends up being kind of like this strange mismatch of, why are we even talking about this sometimes?
Right.
So anyways,
let's take a bathroom break.
Yes.
If you're game. So you were just now asking if we should return to the keto CTA study, and I started telling you something that I realized I don't know that I even have on a podcast, so I'll plug it into this one. I was trying to explain that this podcast is the one piece of work I really find I'm looking forward to all the time. Like, I'm barely getting done with one, and I'm already looking forward to the next guest in a way that I'm not done with anything else work-wise. You've had a front row seat to, I don't want to sound martyr-esque, but the things I've endured, right? Square peg, round hole was where we left before the break, right? That's how I feel every single day. This is the one thing that fits, and it fits well. And it's great because the keto CTA study, I just did not want to take any more time or any more excuses not to get around to the kind of work that I thought I would enjoy. And I did think I would enjoy this. But in particular, I wanted to have a podcast the way I wanted to have a podcast. I didn't want to do another Zoom podcast. I know I could get better guests. I've got a good Rolodex going. But I like this. I like sitting, human experience where where it's like if it were over dinner, we're just chatting. And sometimes it's awkward. Sometimes I'm having my moments where I think, I did that even during this conversation where I stutter a little bit or I'm a little too redundant with words. But this also gets me through my OCD aspects because I can't edit on the fly unless I have to, unless there's a moment where I say, okay, well, let me backtrack on this aspect. But what was fun was right as we were doing the break, you were saying, how long have we been going? I said, guess. You said,
hour and a half.
Hour and a half, right. It's 3 hours.
It's crazy.
Peter did the same thing yesterday. Peter was also curious how long we'd gone. But once you get in really good conversations, right, the time flies.
It really does.
And I love that. I love that. This is such a blast. Are you enjoying it?
Oh my God, so much fun. But honestly, Dave, like, we've chatted on the phone, I think, a couple of times for long periods of time. And I think I told you this, but I was like, I haven't chatted with someone on the phone that long since like a girl in high school. Like, by the way, I think I would love to share with your audience how we met the first time in person. It was funny because I was on Twitter, and I think the first time I ever interacted with you was I had sent you a paper on an SGLT2 inhibitor knockout mouse model that ended up showing some aspects of the lipid energy model. And I think you kind of like maybe vetted me and like looked at my LinkedIn profile and stuff, because I definitely reread that post that I had posted about your journey, which was, I think I had posted it 3 or 4 years ago. I was like, anybody that's into lifestyle medicine needs to be following Dave Feldman, because this is the craziest stuff you've ever heard in your entire life. Anyways, so then after that, I feel like me and you just kind of, DM'd a lot on Twitter and chatted over the phone a couple of times, and like, everybody, this keto celebrity's calling me, like, this is so cool. Yeah. But I remember one time you, I think you were in Omaha for Jamie Seaman's event.
Hard to Kill Summit.
And I saw you, and you're like next to this poster board with like Omaha in the background. And I'm like, Dave, are you in Omaha? On DM, hoping that you'd respond. And you responded, you're like, yeah. Do you want to meet? And I'm like, yes, that'd be great. And you're like, oh, okay. Well, can you meet right now? And I'm like, I mean, like, I haven't taken a shower yet, but yeah, sure. That sounds good. And so I, I like sent you my address, and you were staying, I think, in a hotel, like a mile and a half away or something like that. I mean, very close to where I lived. And I know you had I think it took some time to get an Uber or something along those lines, but you came over.
You were watching your kids.
Yeah. So, yep. Yeah. It was actually before I had my second. So it was just Paxton. And you came over, and we talked, I think, about lipids and transcytosis and all sorts of stuff for probably 2 hours. And then Paxton woke up, and I remember this vividly as I walked upstairs, and I woke up Paxton. I said, hey, Paxton, this is Dave Feldman. He's a future Nobel laureate. I always got a kick out of that.
But I'm not, just so we're clear.
You should be. So, and again, I think if you don't win a Nobel Prize for, the wonderful work that you're doing in, helping humanity and understanding lipid metabolism, I feel like you deserve a Nobel Prize in how just nice of an individual you are.
You're too kind. It's very kind. But I find that I do want to kind of interject something, because I feel like a lot of times people take kindness as being something you're just kind of born with, and like you're that kind of person or something like that. But I'll 100% concede a lot of it is effort, a lot of it is habits, discipline, but there's an actual strategy to it, right? I find if you're trying to be scientific, truly, if you're trying to exercise science, being able to speak to somebody else cordially, trying to keep it respectful, even if they may not have the same and kind response, is crucial. It's crucial to advancing reason, right? And it's tough on social media. But I do believe that it's a big key to my success. And I do find it's one of the areas that I hope I can inspire others. In the same way that I'm inspired by people who I find are very kind. I like to point to the Unwins a lot. They're like some of the kindest people I know.
So nice. Yeah.
But getting back to your story, you have to know that I'm a huge fan of you in particular. I love how many times you've had threads that break down and digest so many of the new papers. I read less papers than I did when I started than when we first met, relatively speaking. But I appreciate how you have such a clear understanding of the lipid energy model. You're watching the science pretty well, but on top of that, you're regularly giving me pings on things that relate back to it. And that's crucial. In a lot of ways, I kind of think of you as the archivist to some degree of all that's happened, as well as all the new ways in which you're expanding and coming up with many new ideas and insights yourself. It's also nice to have somebody who's a lot more into the pharmacological aspects, since, as I mentioned, I don't look at as much. A little more recently, I've been kind of checking into secondary prevention and so forth. That's why I'm kind of a little bit more up on 4S right now. But yeah, I like that everything's come full circle from when we first met all the way up to you literally coming here to Las Vegas to jump in on this show. So thanks.
Happy to be here.
Thanks for making the journey.
And I was going to say too, Dave, that like, I know you had mentioned that like it's a learned characteristic or whatnot, as far as your niceness goes. And I don't know if I necessarily believe you, because I just think you're just a great person whole through and through. But I think for the level of vitriol, maybe, that, or the attacks that you get on you from people that don't really understand your position or aren't open-minded or whatnot, I think the fact that you are as positive as you are, and as that you just remain in this state of, moving forward and trying to be a better person, is something that I think is really admirable. And I think what else is interesting too is that I think you do find people that are in the social media space where the more reductionist you are, the bigger following that you have. And you're kind of like the strange APOB in this multicollinearity. Most of the time, it's the reductionists, it's the goofballs, it's the allos that are saying, just as long as your LDL cholesterol is, insert whatever number he decides to pick on whatever day, is below this threshold, you can't get heart disease. These are the people that gain, lots and lots and lots of followers. I think you and Nick are probably one of the more exceptions of people that are team nuance, that are people that are, trying to be intellectually honest. And I think I think your intellectual honesty was something that was a pivotal moment for me, particularly with that Ivor Cummins interview that you had, that we talked about earlier in the podcast. I remember you caveating everything by saying, I just want to be as intellectually as honest as I possibly can. Therefore, I brought my laptop and I pulled the quotes out of the transcript, and I'm going to read them word for word. I mean, that is just something that, again, you weren't trying to, bad talk Peter Attia. You were thankful that you were on his podcast, even though he made this very uncomfortable and unreasonable pre-buttal. And then not only that, but you took direct quotes from him and you wanted to dissect them and just be an honest interlocutor. And again, I think that is just, again, really, really admirable. And all of us, suffer from some level of bias. All of us maybe, whether we know it or not, might not necessarily be, engaging in what the interlocutor is asking exactly for or whatever. But I think, again, for the number of, challenges that you face, I know that me as an individual, I don't think I would be as strong as you are, Dave. So I am so appreciative of the fact that you continue to stick with it, and you happen to have made a kick-ass team along the way, which is really, really exciting, because, the powerhouse that is Nick Norwitz, the powerhouse that is Adrian Sotomoda et al. God, could you have picked two other people that would be better to carry on your legacy? I feel like you need a break, and I'm excited that you're doing the podcast, because
the missus would agree with you on that.
Yes. Oh God. And your wife too. I was telling Sharon on the way here, I'm like, man, I do some goofy stuff at home with my diet and everything. It annoys my wife a decent amount. I'm like, man, Dave is taking a picture of his food every day for I don't know how long. You still take pictures of your food?
Yeah.
I mean, like,
So we're talking
wow.
a decade.
I mean, like, that's just, I mean, you're gaining weight experiments and you're eating, bologna sandwiches for weeks
so
on
just
end.
think about this. Imagine the nuptials. I'm up there with my soon-to-be wife, and I go, to have and to hold. And by the way, in about 5 years, I'm going to become obsessed with lipids. Do all these different experiments that are going to impact our social life. And further, I'm going to be wanting to leverage your amazing skill set and work ethic to do things like organize giant conferences as just a fundraiser where we won't make any money. I have an amazing wife. There's just no question.
She's amazing. And like, it's hilarious that this is even real life, because it sounds like some sort of, goofy story in a book. It's wild.
That's, for what it's worth, that's, I would argue, a good trick that I come back to a lot that I would tell anyone else, which is whenever you're working through some big moment of suffering, I always have this one kind of internalized mantra, which is, well, it makes the story more interesting. We don't gravitate to the stories of somebody who inherits $1 million and they turn into $1 billion and there's no struggle along the way. No, it's the hero's journey that we're interested in, right? Did you see the movie Rudy?
Yeah. Oh, yeah.
Yeah. See,
Rudy.
every guy I know who's ever watched Rudy, instantly they connect with it. And spoiler alert, this movie's got to be 30 years old now, something like that. But it's a true story about a guy who just really wanted to play for the Saints, I want to say.
It's been a long time.
Yeah, it's a college football team, and he's kind of mediocre as a student. He's not actually a great football player, but he genuinely just wants it so bad, and he's just willing to put up with anything and everything. And when you watch the story, it just chokes you up. I don't care how tough a person you are, especially when you see that it's not some, massive victory lap that he turns out to be one of the greatest football players ever. No, actually, his reward at the end seems not like what you would expect in your typical movie, for which there's a great overcoming, there's a great reward. No, the great reward for him was just to get there, to be a part of it. And the reason we like that is because you really are with him through that struggle. Struggle is, it's cutting steel with fire. No question, if I could go back in time 10 years ago and tell the me of 10 years ago, I know you keep kind of adjusting it to, it's going to take weeks, then it's going to take months, and eventually you'll get somebody interested enough, and then they'll take it from you from there to then do this research. Actually, you're the one who's going to have to try to organize this, get this going. But eventually, you'll be coming into more and more people that will help this along. You're going to have to give up this this peak earning potential portion of your life.
God.
That's all. If you just get no, listen, I'm thankful. It's not like I'm going to the poorhouse. Own Your Labs is doing great. It's sponsoring this podcast, for example, right? And I've met so many amazing people along the way. But, I really want to say this, especially to you. Honestly, just the opportunity, truly, Austin, just the opportunity to feel like you're making just some tiny contribution to the grand scale of discovery is actually pretty awesome. And I cannot get my fellow engineering friends to get it. From their perspective,
Really?
Yeah, from their perspective, I'm just kind of, as one of my friends puts it, it's the most expensive hobby they've ever heard of.
Yeah. You're kind of like this hybrid engineer, I feel like, Dave, where you got like some aspects of, medicine in you and some aspects of engineering in you. And yeah, I can't imagine the level of perseverance that it took to get to this point. And I think it really does help that you're a remarkably intelligent individual too. that you could make all this end up happening, organizing it. And I'm sure the level of frustration that you've had from the difference that is engineering versus medicine, as far as publications goes, as far as just moving the ticker along. I mean, that's part of the reason why, with my company, Digital Conversations, it's like, medical communication is still in like the dark ages. And so
Truly.
it's so I want to be part of that revolution of, really enhancing patient care through that level of communication. But it is just remarkable. And I was telling my wife this earlier today, and I was just laughing out loud. I was listening to your old, I think it was either yesterday or on the plane, but I was listening to your old cholesterol science show where you talked to Peter Landsberg, who, for your audience, Peter Landsberg is probably, top cited lipidologist in the field of FH. He created the Dutch criteria for diagnosing familial hypercholesterolemia, along with John Castelline out in New Amsterdam. And it's so interesting seeing the different mindsets of how an engineer thinks about things versus how a physician, and I'm not trying to dump on healthcare professionals or anything like that. That's not my goal. It's just, it's a different way of thinking about things. And it was funny because Peter Landsberg was like, you guys were talking about HDL cholesterol. And Peter Landsberg, we don't know what's going on with HDL cholesterol. So, it's very complex and, it does this and that. And sometimes high is not good, but sometimes low is, we don't know. So we just, we kind of disregard it. Disregard it? What? And I'm thinking to myself, I'm like, God, I was riding that giant roller coaster. I think it's called the High Roller down on the Strip in Vegas. And I'm thinking to myself, I'm like, man, if one of these engineers just, that tension in that wire there is just looks really complex. Let's just ignore it. Whatever. Right. It might be something in this case, but maybe not something in this case. And so, what I can't even imagine the level of complexity that it would take to design a cloud-based platform or whatever, object network, whatever you do. I can't even imagine how complex it is to create a building or a Ferris wheel that is that big and gigantic. Ferris wheel, period. You can barely make it out of Tinker Toys. But the fact of the matter is that, you guys don't want a stone that's not unturned. You want to understand it in and out. You will do everything that you can to make sure that you do it right, because that's the way that it has to be. Like LipoFan will send me all these pipe analogies and stuff with tension and stress and corrosion factors and stuff like that. I'm just like, my head is spinning and stuff. We just got a huge blessing that the person that ended up taking up, and maybe it was going to be another engineer or something like that, but I'm glad that it was you, and I'm glad that you did it. And I'm glad that you're an engineer. And I'm glad that you're thorough. And I'm just, it's so exciting to see more of this data evolve with time. So, okay, I'll stop crushing on you so much. So
again, thank you.
Yeah. Thank you.
It's good to be at this point in time truly, this is the moment where we're crossing the finish line on the original scope of the original study. Even while the extension, knock on wood, is coming, while the triad study is coming, this was the thing that we were waiting for. And I still can't fully absorb it, that we're really here. I will say, I love that the first preliminary data, quite literally the first baseline data set, we managed to work out Jen Eisenhart coming on board to capture it with the cameras right there real time. And you're seeing my reaction as it happens. And I'll show you a little funny insider story. It's quite literally the first time I'm getting filmed. But it really is when Budov is actually showing me the slides. And I'm sitting here, I'm waiting, and finally he's showing it to me. And I'm getting it, and I'm actually absorbing. You can see It's a genuine reaction. It's not staged. But as I'm getting it, I'm just dazed and I'm really contemplating it. And it was just like in the movies where there's an edit, you're hearing some faraway voice and wah, 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 wah. It was the director of photography who is going, okay, I want to get this from like a different angle or something. And I was just sort of like looking up, and he's got it on film. You see me doing it where my eyes are glazed over. I'm only 10% there to hear what he's saying. And I'm not taking the direction well at all because my life is in that slide that boot off is showing me on that screen. And it was amazing. It was amazing because I think you saw what happened 8 days later at Low Carb Denver. Weren't you at that conference? 2023.
I think I paid for the videos of it, but I don't think.
Okay, because 8 days later I present this, and I broke out those 4 scenarios that were in my head this whole time, entire time.
Yep. No, I definitely paid for the video. I didn't attend to that one, but yeah, go ahead.
Scenario 1 was, of course, the worst case scenario, which is sometime in the middle of it, someday, as the study's going, Budoff's calling me. He's like, I'm sorry, I wish I had better news, but we've gotten too many participants that have high baseline plaque. We've got to stop the study. That was scenario 1. Okay, well, we obviously got all the way to the point of all baseline scans being taken. So now there's scenario 2, which is, well, it does look like a high-risk population at baseline. Scenario 3 was, it doesn't look like a high-risk population at baseline, but we do have a lot of outliers up over on this side. And then there was this scenario 4 that basically everybody had, there was still a spectrum, and I don't want to make it sound as if on one end there wasn't some people who had plaque, but the total plaque score was remarkably low. And it wouldn't be until, I guess, a year and a half after that we got to do the Miami Heart match analysis. That, to date, even against the longitudinal data, as excited as I am about the longitudinal data, the match analysis was probably, to me, one of the most powerful moments. Maybe the most powerful, because we just didn't have any cohort to compare them to. And we discussed this a little bit earlier with regard to the challenges in looking at anything post hoc, which should always be very careful on the approach. But that said, while our new study with the triad study will have an attached control group, there are pros and cons with having your own control group that's in a study versus doing what's known as a match control, which we did with Miami Heart. Mm-hmm. I like a match control, as long as there's not a lot of adjustments and modeling applied after the fact, because you can, through stratification, grab a cohort that already matches up in every other way you can, as long as you can find a population that had it, which Miami Heart did. And here we are, apples to apples. And the fact that we got both the match and we got longitudinal, and they're all very consistent with each other. I'm just heartened that we really are at this point where we have this much data in hand to say what we can say about lean mass hyperspars. Okay, I will go ahead and throw in real quick limitations, as I should. It is in fact a 1-year study, sure, but it is half a decade, to be fair, since baseline. And it is possible, got to be a good scientist, it is possible if we get the 5-year data that a correlation will emerge between, say, LDL and atherosclerosis, or maybe with ApoB and atherosclerosis and not LDL. Don't know. It'll be, what I'm also interested in is inflammatory markers versus plaque progression, whether or not we'll see that. Those data are coming soon, but
I'm excited for those data.
Yeah,
sure.
I'm blinded. This is one of those rare times where Adrian has data that I don't have access to because he's the designated statistician who helped us put together the paper. But I'm very careful about the questions I ask. They should all be justified as the funder. Otherwise, I would be no better than any other funder that's
Right.
just trying to get the answers that he wants and keeps asking the questions until he gets some. So I'm careful about that. We should mention one more thing, which is on that very topic. There's only one time in which I asked for a serious analysis post hoc that was different than what they had already handed off to me. You know where I'm going.
It's like you're reading my mind.
Yeah.
I was going to ask, so go ahead.
And that's when the original match analysis that was chosen by Lundquist, I didn't have input on this, included for the Miami Heart cohort 1/3 of the group being on lipid-lowering therapy. After I was presented with the data, I did protest a little bit. I was like, oh no, you've got folks with lipid-lowering data. And they said correctly, actually, it's just very difficult to get a population that isn't on lipid-lowering therapy. Well, so I turned this around. We did the not only the publication, but also on top of that, we also did podcasts around it. And there's a podcast with Simon Hill where I had Bill Cromwell on it. He got to see the publication even before it had been published for the match analysis. And both he and Simon had brought up this issue. And I acknowledged at that time, and would acknowledge now, that is something that I think is relevant to discuss. I don't know how much. Some people came to the conclusion that the 1/3 must therefore be suggestive that they had higher overall LDL burden than our match group. Probably losing a lot of people by discussing this, but I'll just put it this way. There was an interest in seeing if we can take that match analysis that was those folks from our cohort, which I think had an average LDL of 272 in this group, versus Miami Heart. And the Miami Heart that had the 1/3 that were using cholesterol-lowering therapy, if we could stratify, if we could exclude that 1/3, and then whatever was left over, match again against our cohort and cut off the 1/3 that wouldn't match so that we can then do another like-for-like comparison.
Right.
And we did, and I presented it in Low Carb San Diego. And also no statistically significant difference between those two groups.
Did you ever get a response from anybody on
I
social
had yet to get a
media?
response from anybody. I specifically pinged Simon Hill because he was the most vocal and interested on seeing those data, but I hadn't heard yet on them.
So the idea was that, like, if you did include statins in that, then you would be looking at an artificially, maybe higher risk population or something along those lines that might have a slightly higher vascular burden, so that they might look like they're healthy, but really they're not because they're on statins, or there could be something underneath the hood that's why they were.
Right.
That's why they wanted those removed. Yeah.
So if I'm steel manning them, I'm going to put it this way: our cohort had an LDL of 272. The Miami Heart group, since 1/3 of them were on statins, that 1/3 may have had higher LDL until they adopted statins.
Mm-hmm.
And that's not reflected in what their baseline LDL is.
Sure.
Now, I think that's 100% not only fair to bring up, but hey, let's figure out a margin that might be considered. But when I was doing the math to try to see if what was being claimed as plausible, that actually altogether that 1/3 could account for a greater absolute level of LDL when compared to our group that had 272. Sorry, I should mention this cohort had an average of 123 LDL cholesterol. If my math is correct, that would mean that 1/3 had an average LDL of 190. That seemed very implausible.
Unlikely.
Yeah, unlikely.
To say the least.
I never quite saw how that math could work out. But again, for those folks who did have that concern, that's why we did this additional analysis. Lundquist complied with my request. And the only reason I made that request, the only time that I made a post hoc request, was because I agreed that was something of interest, and it was the most prominent claim made, and I think one that everyone would agree with on both sides of the fence. So I felt,
a good idea.
What the heck, I'll go ahead and do it, and I'll present it.
It just would be nice to get some acknowledgement, from individuals that are requesting that data, being like, hey, that's interesting. Thanks for doing that. that, shifts my doxastic state or whatever you want to call it in philosophy, one way or the other a little bit. From the longitudinal data, I have to ask you, did you find anything surprising in particular?
I want to give a good answer for this because I do my best to have epistemic humility. I can't say that I made granular levels of prediction. I'll bet if I looked hard, I could find something, but the broader themes of my prediction were what I've quite literally been stating over and over again on social media. And as best as I can, trying to wrap it in the genuine uncertainty that there was. Even if I was cautiously optimistic. I can say this now, by the way, now that the data are in hand.
Yeah.
Right?
You don't have to censor yourself on a very censored phrase
that's
anymore.
Actually there, that's actually in hand. I can't say I'm surprised at all, and I can kind of back up everything that I was saying. So here's a great example. Something a lot of people were predicting was that there would be no plaque progression at a population level, and I pushed back at that regularly. I said, no. First of all, it's a middle-aged group of people, mostly male. Put me on record for predicting at a population level they're going to have an increase in plaque, but that's because every population of 55-year-olds, once you get sizable enough, is going to have a progression of plaque. Don't get me wrong. As I said to Brett Shearer once this came up, I'm open to hear any population that does not develop atherosclerosis or has no progression. Whatever protocol they're on, everyone's going to be interested in getting their folks on that. I know there are many claims that are made, and I know even in the case of, say, PCSK9 loss of function, there are data to suggest that cardiovascular disease risk is lower, relatively speaking. They still develop atherosclerosis.
They do. By the way, we can talk really quick about PCSK9 loss of function, because there was a really interesting study that I was just kind of perusing through prior to hopping on the podcast and stuff, maybe like a day or so ago. And it was the sequence variant PCSK9 publication in the New England Journal of Medicine, really high impact journal. And this is the one that's oftentimes cited by a lot of the entire population needs to have really low LDL individuals. And what's really interesting is that if you look at the PCSK9 loss of function, and this was in African American ancestry, PCSK9 loss of function, the difference in LDL cholesterol was like 30 or 40 milligrams per deciliter between the control group. But the relative risk reduction in major adverse cardiac events, as they categorize them, was like 88%. Meaning that this PCSK9 loss of function variant, even though it didn't drive their LDL cholesterol to 10 to 20, which is what most people think happens when you have, PCSK9 loss of function or whenever you look at those studies. In this case, it was the difference between 130 or 40 and 100 milligrams per deciliter. 88% relative risk reduction in major adverse cardiac events, putting this in quotes. I mean, doesn't that strike someone as strange? When you have these fancy meta-regression analyses from Meta-Analyses that I just mentioned
earlier, that for each 1 millimole,
which is
right,
38 milligrams
right,
per deciliter.
Milligrams per deciliter, there was a 25% reduction. This is what you're describing right now is close to that, right? Let's say 40 milligrams per deciliter drop. There isn't a 25% reduction. There's an 88% reduction, which is crazy, ridiculously high.
Yes. And this is also, again, where I think sometimes the statistical wizardry comes into play, because if you actually look at how those events were adjudicated in that trial, it was like, they included like people that had maybe like silent MIs or like changes on EKG or something like that, was counted as a cardiovascular event. So that can absolutely inflate the benefit of, this PCSK9 loss of function cohort. Not to mention, and this is what I think is really interesting about PCSK9, is that when you look at PCSK9 levels that can be measured in the blood, if you adjust those levels for LDL cholesterol, they still predict cardiovascular events. So in other words, there's almost certainly some pleiotropy with respect to PCSK9 as a molecule in inflammatory responses, in angiogenesis, in smooth muscle cell recruitment, and probably a whole host of different mechanisms, which again I find interesting, which would basically throw another wrench in the notion that it's all about the LDL-C reduction for all of these agents and stuff. Again, I think it harkens back to probably some of like the Bradford Hill criteria from the EAS paper. Consistency is just, I have trouble with that specific criteria in that paper, because
in other words, to get back to Bradford Hill, part of how you make the case for a given exposure to a given outcome is all these assessments, and one of them that's a big and important one is consistency. These claims that are made, like the one you just mentioned, where they have these nice clean lines and like everything, all the dots just perfectly line across it. The claim that is being made is that look at all these different lines of evidence, they all agree with each other as to the amount of lowering and the corresponding outcome benefit. Things like this that would have been thought to be one of the best ones don't seem to line up consistently.
And we see that in other drug trials too. I mean, even this is what I find interesting too, Dave, is like, and again, hearkening back to the pharmacy side of things. I know you have beat the drum to a degree about the changes in regulations with respect to statin trials that occurred in, I think, 94, 95 or something along those lines. Do you recall, what I'm talking about?
Yeah, I think what you're referring to is what happened in 2004.
Oh, maybe it was 2004. It couldn't have been 94, 95. Yeah, it had to be around 2004. Yeah, where basically
two things happened around that time. Both are very relevant. One is that there was a requirement for registration that wasn't quite as prominent as it was before. So there could be trials that were happening and failing that no one knew about, and therefore would never be understood to be a problem.
Right.
But there was another one that, and this is a good place to open an important topic, but I'll just say what this other one was, which was that past that point, past 2004, it was considered that statins were so important for anybody at any level of cardiovascular disease risk that even in the placebo group for future randomized controlled trials, there needed to be some level of statin therapy. That's my understanding. Mm-hmm. And therefore, there really, past that point, was no true placebo group in any cholesterol lowering study of any kind. I don't think there has been any since 2004. I think that was the main change.
Mm-hmm. Yeah. And I think there's also some stipulations with respect to some independent verification, maybe in the way that events were adjudicated. And anyways, it was clear that there was some level of identification where there needed to be more data transparency. I think that's fair to say. What I think is super interesting is that if you look at these two clinical trials, which I brought up on Twitter before and I find to be fascinating, it's the CARDS trial and the ASPEN trial. Okay. So these are both trials that are looking at the use of statin medications versus placebo in individuals that have diabetes. And if you match up like the LDL-C reduction, the intervention, which was 10 milligrams of atorvastatin versus placebo in each one of the groups, the only real difference is that ASPEN was a mixed bag of both secondary and primary prevention, whereas CARDS was a bag of purely primary prevention as far as they knew, because nothing was stratified by CAC or anything along those lines, coronary artery calcium. But what they found was that in CARDS, this is the trial that is touted within the lipid lowering community as the best study to show that there's benefits to statins in individuals that have diabetes, as far as, it's 40 to 44% reduction in major adverse cardiac events, relative risk reduction. In Aspen, same cohort, except for slightly sicker probably because some of them are secondary prevention. And usually the magnitude of benefit of certain drugs tends to be bigger the more disease you have, the sicker the population is. It was a completely non-significant endpoint in that trial. So they're basically identical in design and intervention. The only difference was one was before those regulations and one was after the regulations. I'm just going to pop on my little tin hat here for a moment. But like that stuff just like drives me crazy. Like it's wild to me. And so I think what's fascinating as well too is that if you take all of the trials that were designed for diabetic patients, so in other words, in the inclusion criteria with this clinical trial, it was diabetes. There's 3 trials. There's CARDS, Aspen, and one called 4D. And this was in diabetic patients that were on hemodialysis. What we know is that statins, for whatever reason, don't work in individuals that are on dialysis to lower events at all. So when you amalgamate all 3 of those trials together in a meta-analysis, there's no benefit of statins. Even if you take out 4D though, and you combine CARDS and Aspen together into one trial, you still don't see a significant reduction in events in individuals that are given a statin that have diabetes. So I'm not suggesting that, everyone that has diabetes that might be listening to this podcast should stop their statin or anything like that, because there are, other subgroup analyses, post hoc analyses. There's a lot of data of statin use in diabetic populations. But, I think that level of evidence is weaker because it is a lot of post hoc. It's a lot of subgroup analyses. And if I was being a good skeptic and trying to be logically consistent with the way that you evaluate evidence, then you'd almost have to come to the conclusion that with respect to the highest quality data that we have, there's no significant benefit of statins in individuals with diabetes. I can't wait to get all of the hate mail in for saying that. But I would love, so I'm sure you're familiar with ZK for Trey on Twitter, but he's an interesting individual that I would garner as a relatively smart guy. And I like, and granted, he's very crass and a rude individual too. But we were chatting back and forth about this. I mean, he had absolutely zero answer for what I had posited, which is when you actually look at trials that are designed for this intervention in the population that you intend to treat in, you don't see an effect. And I think that's I think it's a big problem. So again, this all kind of, the reason why I bring this up is it harkens back to this statistical wizardry, this data mining, this, it just gives me, it makes it hard as a clinician to feel super confident, I guess.
It's a challenge I have with modern drug trials overall. And for me, it's lose-lose to even address what my issues are. I have mentioned this before on other podcasts, and I'll go ahead and mention this now with, of course, the caveat that I don't want this to become a means by which you then disregard all possible, drug use. But it is not just my issue. You can find many other scientists, clinicians that bring up these same issues. Number one is and this I think is just a no-brainer, I don't like when trials are powered to events. There are lots of issues with this, and it can create all kinds of wonky extrapolations that wouldn't necessarily hold up if it actually ran the trial's original length. 2, for the life of me, I don't know why it's acceptable to have a run-in period. I genuinely don't get why the scientific community at large doesn't push back on this concept at all. The run-in period, for people who don't know, is you recruit the population you intend to run the study on. You put them all on the given drug that's going to be the intervention. And that gives an opportunity for a number of them to leave the trial. So if they're potentially experiencing side effects, they can then step out of the trial. Well, of course, then you're going to end up with a study that likely is underreporting what would be the same quantity of side effects that are in the field. But on top of that, it could be that there are bigger problems than just it upsets my stomach or it gives me a headache. It could be that those side effects could be much more severe for those folks that experience that first and then something worse later.
Mm-hmm.
Right?
Yeah. Yeah. And it actually introduces, because I know healthy user bias gets thrown around quite a bit on social media. And I think that if you actually look at the strict definition of what healthy user bias is, I think people are actually talking about multicollinearity. But, in healthy user bias, there's a type of individual that's going to, maybe stick through the run-in period too. That could be randomized to an intervention as well. And so again,
you're getting to adherence bias.
Yeah, it introduces some level of a change in the patient characteristic as well too. That might be a little bit more subtle, and maybe that's clinically irrelevant. But it's just, these are all the little things that kind of come into play when we look at evaluating evidence. And just, I think as Adrian Sotomoto said at COSI, causal inference is just really hard.
Yeah,
it's just really hard.
And I don't get this. I don't get why we can't acknowledge that data come in a spectrum, and the degree of confidence we should have can also be in a spectrum. Why does causal inference have to be binary? Why does there have to be this leap from a hunch to I'm absolutely confident this thing causes that thing, right? It's frustrating to me because I think we can and should be practiced at saying the data is pretty good for this being part of the causal pathway. But, we don't have strong enough data to even make a recommendation on it. Like, that should be an acceptable sentence to say. But instead we have, red meat probably causes cancer. Really? Can I see the data behind that? And that's some of the weakest epidemiology that I've seen. At least me personally. I don't know if anybody's going to put something new in front of me that's going to be very compelling. But this is why I like to bring up Bradford Hill. I used to think, because of how many studies claimed to have met his criteria, that he must have been a pushover. He's not. If you really read up on Bradford Hill, he himself, in his own, I think it was the speech where he introduces the assessments, brought up how a hazard ratio of 2 is not that exciting in the discussion of smoking, right? That hazard ratio of 2 wasn't something they would find as compelling. And I think it was when he was bringing up where there's such a strong association, particularly with smoking and lung cancer, for which you have a hazard ratio that's far, far, far higher, right? And now it's meeting a higher threshold basis for him. So, yeah, I think you've got to, for me, I don't know that I even want to look at it if it's having to use a lot of deep statistical modeling and especially extrapolations to make a case that eventually it'll meet a hazard ratio of 2 or higher. As long as we put this here, we place that there, and so forth, and we get there. I like, this is something I do really like that Peter Attia brought up in one of his podcasts. He said, at the point where you don't need a p-value, you're there. I like that. I like that for making causal inferences. If you don't hardly need a p-value, if you can see the correlation pretty strongly yourself, which is kind of commonly the case with, say, something like smoking, the thresholds are so strong. But even then, randomized control trials are the best because they at least make the confounders you are unaware of not matter as much.
Right.
But even so, there's still problems with randomized control trials.
There is. Adrian Sotomoto, again, wrote a great piece on this too, about, where you get randomized at and what institution you're at and how that could potentially introduce bias. And yeah, it's a challenge. And it's so fun to see some more of these analyses too, that are bringing a level of rigor to some ways of looking at observational data in very creative senses, like the specification curve analysis. Are you familiar with that? With red meat and all-cause mortality, they did this. It's called Grilling the Data is the name of the paper, and it's like a specification curve analysis of red meat and all-cause mortality. And basically, what they did is they found out the number of covariates or confounders that they could adjust for, and they found out that they could make 1 quintillion something crazy high number of studies. And what they did is they took that bazillion number of studies they could make with all the mixing and matching of all the different adjustments they could make in the model. And they took a smaller sample of that gazillion studies. I think it was like 1,700 or something like that. And they analyzed that, and they found no effect of red meat consumption in all-cause mortality. So again, I'm not saying like red meat is not associated with anything or whatever. I don't know that answer for sure. But what I would say is that I think, unfortunately, the way that these models are put together, they're adjusted in certain ways that, get the authors get the answers. And again, if they get those answers too, I'm okay with a cautious interpretation of that, or just state that there's a lot of limitations, that this is, maybe more hypothesis generating. But it's when you're like dogmatic about it and like, you need to stop doing this and you're killing people.
Implementing policy.
And implementing policy.
At the point where you're actually changing laws, at the point where you're actually changing school lunches and things along those lines, you've got to have strong data to back that up. Anyway, it's
scary. And I think what's interesting too is that even very avid proponents of epidemiology and epidemiological research like George Davey Smith, who is the father of Mendelian randomization, when that recent butter and olive oil study came out, or butter and seed oil study came out showing that seed oils were better than butter or whatnot, for a whole host of outcomes and stuff. George Davey Smith commented on it and was like, yeah, another trash study. This is just garbage, And this is a guy that like is probably one of the top 10 most prominent. I'm not trying to do like an appeal to a authority fallacy here, but like if you have someone that's like, that understands this modeling in and out to a profound degree, to the extent where he created like his own field of, trying to find ways of better causal inference, and he's saying that it's garbage, it's like, come on, like I feel like that says something. But then you get the other folks that will say, well, if you look at those analyses that compare bodies of evidence, where they look at randomized controlled trials versus observational trials, and I think the most recent one was like there's like a lot of concordance between those two bodies of evidence.
You're talking about where there's a push in a given paper in saying, hey, actually, because there's a lot of correlation between a meta-analysis of RCTs on subjects A, B, C, and D. If you look at the epidemiology on subjects A, B, C, and D, they actually align a lot. I've looked at, I think maybe even the same paper you did, and there was a huge amount of subjectivity in how they determined what those things were, because it wasn't that quantitative. There was a lot of more or lessness.
They like broadly agree with each other, is like the terminology that they use.
Right.
And the other thing too, so like you'll get a lot of the people that just really want to hammer home epidemiology, that it's like a great, really helpful tool for causal inference, to say, well, what's your standard for causal inference? What type of data? People say RCTs. That's the best quality evidence. Well, did you know that observational data correlates really, really well with RCTs in the field of nutrition? 80, I don't know, maybe 80% or something like that. And the challenge is that even RCT data in nutrition is really hard too. It's really hard. All of these hazard ratios for all these effect sizes are clustering around 1. It's very small hazard ratio. So yeah, they're all at 1.1, 1.2. Yeah, they're going to all look like they correlate super well together. So the effect sizes are really small. And, unfortunately, a lot of RCTs still suffer from the same limitations as the observational studies. Food frequency questionnaires that are sent out, or, hey, I'm not randomizing you to an actual diet. I'm telling you this is how you should do the diet, and then I'm going to follow up with you in 12 months and stuff. And there are good things that we can garner from data like that. And it's not like that's all just trash, but just to use that as an inference to say that epidemiology is great because it totally agrees with RCTs.
Yeah. Look, I say this often, and it's just true. Epidemiology is great for hypothesis generating. And I don't say that to be dismissive of it. Hypothesis generating is super important. We have to do it. And of course, observational data is a means by which we can get there. But epidemiology, whether it just needs to be acknowledged when it's trying to be used to make a claim of causality. When you run a sensitivity analysis trying to determine what all of these other factors are that are creating another form of causality. You're technically making multiple causal claims, whether you admit that or not. You're saying, hey, I think A is this much causal, B is that much causal, C is this much causal. And then once I've added them all together, I know that D must be this much causal because I've subtracted the others. Almost nothing works that way, especially in complex systems, right? But I have another answer, which is the best way to test your model of how you've done those quantifications is predictability. What model in epidemiology around lipids predicts our study, or for that matter, predicts lean mass hyperresponders? The phenotype of lean mass hyperresponders, if lipids are so well understood, there should already be a model in place that could predict how that would manifest, and for that matter, what the association of plaque formation would be. I made this joke, it was a bit glib for me, but I made this joke on Twitter, I want to say a few years ago, but I said, pro tip on, I believe this is how I said it, pro tip on how to become ridiculously rich. Do you know this one? Yeah, it's like at the stock market. Just adjust for all the confounders, and then you can only win, right?
It's so funny because I plugged that analogy into ChatGPT too. And by the way, I love ChatGPT. I think that it hallucinates and does some goofy stuff. So I'm not just gonna say it always gives the best answers and stuff. But I did plug it in. I'm like, what do you think is more likely to give reasonable causal inference? The associations between a nutritional exposure and outcome versus, stock market data and what an ultimate stock is going to be. And it was hilarious because it just went through a myriad of reasons as to why it would be orders of magnitude easier to predict outcomes in the stock market. Data that comes in right away, multitude of data, so many different variables, general previous trends, blah, 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 blah. And it's like,
and this is why, I hate to say it this way, but this is why epidemiologists should be filthy rich.
Yeah.
Because then you'd
adjust the models.
Yeah, you could just model against the stock market and then you'd win.
Yeah.
Right.
And again, I don't want to sit here and just trash on epidemiology because there's clearly good use cases for it and stuff like that. And, and again, I'm a humble human being. I've been wrong many a times in my life. I'm okay to admit that I'm wrong. And, if I'm wrong about epidemiology and someone wants to set me right, great. I'm all open for that type of conversation because I just want to be as right as I feasibly can. But boy, it's just, I feel like there are so many portions of it that, and maybe it's just my own ignorance, but I just feel like there are so many portions of it that just seem so brutally hard for me to wrap my head around to the degree where this makes any level of sense. Even the heterogeneity with respect to diabetes, that is a very heterogeneous disease. You get an elevated glucose at the end of the day, but you could have really profound pancreatic insufficiency. You could be one of those individuals that just their pancreas poops out really fast once they get a little bit of fat in it. And that causes a decrease in production of insulin and glucose levels to rise. You could be one of these people that just loves accumulating fat in their liver. And then you get a lot of fatty liver and gluconeogenesis never stops because you never get that insulin signal to stop
There's
it
a
up.
genetic disease, glucokinase deficiency or something. Basically,
GCK, yeah.
And it results in high levels of glucose, but doesn't have any impact on your diabetic risk.
Right, exactly. And it has nothing to do with either, it doesn't have anything to do with the twin cycle, fat in the liver, fat in the pancreas type of thing that culminates in elevations in glucose. That's a form of MODY, is what they call it.
But see, this is where you're going is where my complaint lies in turning this unnecessarily into a binary discussion.
Right.
Because epidemiology, again, I'll restate what you and I both believe, which is epidemiology, just observational data sets in general are very powerful. They just shouldn't be overplayed. That's where we get into a problem, right? It's like in a toolbox, I may be using the hammer the most for things that the hammer is good at being used for. Sometimes the hammer can be used in a special case for something else, but only if it's the best tool for it. It's hard to prove causality with epidemiology, particularly in things that have long time horizons. and in a complex system. It's difficult to disentangle. I don't love when the most common argument for why we should use epidemiology to make a causal claim is that it's the best we have.
Damn it. I
It's
knew
my
you were going to say that.
least favorite statement, right?
I hate that.
It's, hey, it's hard to do a long-term diet study, so we'd have to work with something.
Or we can't do a long-term diet study. So, this is just the best we got. And so
that doesn't turn it into good data.
that doesn't mean, and again, it's okay. Acknowledge it. Acknowledge its limitations. Don't put these really strong arguments forth as that being a reason to change some aspect or intervene in some fashion. The level of evidence needs to be attributable to the level of the recommendation. So yeah, it's the best we got, but just acknowledge that it's not that great, and don't go on someone's podcast who's doing a carnivore diet who happened to put their epilepsy and ulcerative colitis into remission and tell them that they're killing themselves because you looked at a meta-analysis of epidemiology studies that looked at red meat that says that everybody dies of colorectal cancer. It's just crazy. You want to hear something funny too, Dave? When you look at the data on the risk of colorectal cancer with ulcerative colitis, very high risk factor for the development of colorectal cancer, ulcerative colitis, a form of inflammatory bowel disease. Nick Norwitz happened to put his ulcerative colitis into remission, biopsy proven, with a lot of probably animal products and other, things that tend to be associated with colorectal cancer. So, if you have something that has orders of magnitude more of an effect size on the risk of developing colorectal cancer, and yet you use another thing that's associated with colorectal cancer to completely abrogate that risk factor, maybe there's some residual confounding in the red meat group. Maybe, the people that eat the most red meat do all of these other behaviors. And again, I probably sound like a broken record with respect to these arguments that are played out. But
but now you're talking about real healthy user bias. So we were talking about adherence bias before, but healthy user bias is a thing. Again, this isn't just yours and my novel opinion. This has been written about forever. People who are more likely to eat red meat probably have been disregarding the advice we've been hearing for the last 40, 50 years and are therefore also more likely to smoke, also more likely to drink, and there's plenty of science behind this, right? They're less likely to listen to their doctor, and they're less likely to exercise, and so forth. This is, again, a problem with trying to use things like sensitivity analyses to try to determine how much healthy user bias itself is part of the causal confounder and then subtract it. There's no way around it. You're doing it statistically. This is where it is a beautiful thing that we have this new group of people who are health conscious red meat eating to be able to test this. And again, I like this from an experimenter's point of view. If you've got people like lean mass hyperresponders who we now have, this actually was one thing that I did like with our paper, is that we had their dietary data. Mm-hmm. So you could see they were a lot more. I'm going to actually zoom this up a little bit. So for anybody who's checking out the paper, because it will have been out by this point, this is table 2, diet composition. I mean, they were very low carb. I know a number of them were carnivores only because they outed themselves from within the group. But carbohydrates, and this is 39.5 for the carbohydrates, but the fat was 120.2 grams. Saturated fat was 44.7. 44.7. And yeah, the fiber, 7 grams, 6.9. 7 grams of fiber, average, for our cohort. So very little fiber, very little sugar, and yet a lot of fat, a lot of sodium, right, in our cohort. This helps if you're thinking a difference of, I don't know what it was in the red meat study that I was looking at. It was like a difference of so many ounces or something. You then throw in a population like we're seeing with lean mass hyperresponders who tend to be on diets high in red meat. If there's a very rapid linear association between the amount of consumption of red meat and something like colorectal cancer. We should be seeing it very quickly. And will we? I don't know.
I think it's just, yeah, I think people really like, I think human beings in general, this is a little bit more meta, but I feel like human beings in general just like the idea of individual constituents in food having some sort of, magical effect or, alchemy type effect. We just like, as human beings, I think we always gravitate towards, this is some compound that antioxidants and phytonutrients and epicatechins and flavonols, and there's this plant in the middle of the Amazon rainforest that if we were to finally find it, it would cure cancer and blah, blah, blah like that. We just like to think of food like that, like cholesterol is bad or saturated fat is bad or this or that is bad, or we need to get more of these. And I feel like it's really hard to reconcile the bulk of all of the anecdotes that come out there, other than the majority of chronic disease is just an energy trafficking problem. It's a global issue. It's not like you eating an extra cup of blueberries is with the antioxidant load that it's going to give you is going to end up resulting in any sort of clinically significant outcome over the lifespan of a human being. I think that the bottom line is, and I get this, I encounter this with, individuals that I work with all the time, patients in particular. Oh, I'm going to try to avoid that red dye, or I'm going to try to eat organic instead of non-organic. What we need, I think it needs to be a shift over to a dietary pattern that is high satiety, that is going to improve your global metrics of your health, improve your body composition, rather than focusing on beans will lower, avocado, the recent one, avocado lowers, when it's substituted with dairy, it lowers your risk of heart disease and blah, 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 blah.
It's this simplicity obsession.
It's so wild.
This is the larger challenge that I think I've discussed with you a number of times, in particular in private. What I didn't anticipate, and I would argue maybe the thing that took me the longest to fully grasp, is that we like simple explanations, particularly simple problems that have simple solutions. Now, instinctively, you might think, oh, that's because they're easy to understand. It's easy to understand that when there's a simple problem to a simple solution. That's true, yes. But it's not just that. There's actually a desire for things to be that simple. So, of course, beyond just LDL is the main problem, and here's the solution to change the LDL. Okay, good. Same thing with diet. A couple blueberries. Oh, that's what I need. Whew. Okay, I can still continue eating pizzas and my cheeseburger and fries and I just need to be sure that I fit in that cup of cod liver oil. I hear this has great, what's the vinegar one? The
apple cider vinegar.
Apple cider vinegar. That's some pretty serious new hotness, right? Now, I think there are a number of things like, say, vitamin D that are meeting a deficiency, and that's legit. If you have a vitamin deficiency that's quite commonplace in the populace, then it's not that vitamin D has special immune boosting powers. It just might be that quite literally a lot of people just need more of it. And if they can supplement it instead of getting outside because they're not going to get outside, cool. At least do that much.
You're talking at like a pharmacological dose almost, though, of vitamin D, 2,000, 4,000 units a day per se. When you look at the amount of certain phytochemicals and things that are found in food, granting that they first pass metabolism, granted that they get through the gastric lining and the gut and make their way to portions of the cell that they're supposed to affect, etc. You're under so many different assumptions that, again, yeah, I agree with you. I think they end up missing the forest through the trees. I don't care, and this is what I've told people 1,000 times before. People are like, well, so can I eat red meat, or can I eat these types of things? And again, this might be completely wrong, but oftentimes my idea is like, I don't really care if you eat a vegan diet. I don't care as long as you supplement or whatnot. I don't care if you eat beef, butter, bacon, and eggs for the next 90 days. If you end up losing fat mass and gaining muscle mass from where you are right now, I would say that you're likely extending your health span and your lifespan. And it's like when people start to get these substitution analyses of, PUFA with saturated fat or something along those lines. Okay, so like there's some sort of nominal relative risk reduction and, whatever, maybe even events, but not mortality and yada, yada, yada. Again, the thing that's going to help this person probably is not worrying about saturated fat, but trying to find a dietary pattern that they can adhere to,
right,
so they improve their body composition
right,
and lose weight.
Getting back to the disastrous distraction.
Right.
If you find yourself overly focused, not even just on a food, but also on a number, to a degree in which you're not taking care of your actual metabolic health, at least if you're going to hyper focus on one thing, just look at metabolic health. That's worth focusing on. But I say this often myself, whether it's vegan, whether it's Mediterranean, which I think is just this umbrella term that gets used for so many different things. Whatever that diet pattern.
No, it's the Mediterranean diet.
The Mediterranean diet. The exact composition of the food is less meaningful than you want to believe it is. You want to believe it is because you want the simplicity of a change that you're still going to enjoy consuming. But look, the only reason you're exploring the topic of a dietary change is because the diet you're on is not working. And unfortunately, pretty decent chance that that's some version of a standard American diet. This is why almost every fad diet looks great when it's compared to a standard American diet, because, and I'll bet you'll agree with me on this, I speculate it's probably in the neighborhood of 80% of a benefit of any given diet, including keto, is that you're leaving the standard American diet. Now, it doesn't mean that there isn't a lot of optimization past that point, but the standard American diet is just that terrible. It's so terrible.
It's so bad. Yeah. And it's the terrible combination of high fat, high carb, slight amount of protein, adding some salt on there makes it not only, I think, hyper palatable, but also from a biochemical standpoint, activating the Randle cycle and a whole host of other things that just ends up just causing a profound amount of metabolic disarray. I mean, it is a terrible, terrible thing. But you always look at that McDonald's guy that ate half of the amount of McDonald's that he was supposed to, that he budgeted eating, and he lost weight, and every single one of his objective measures of health tended to improve. So again, is he going to be able to sustain that long term? No, because satiety is going to come and knocking at his door.
He did your original diet.
Yeah, hunger drive is going to come knocking at his door, and there's a lot of adaptive processes that occur as we lose weight, and so good luck to that unless you change the quality of your diet. You can change the quantity, you can white knuckle it for a while, but the challenge is that if you're still eating the same suite of foods and you don't address the quality, then hunger is going to come back and you're likely to regain the weight that you lost, in my opinion. So, but anyways, I always caution about these substitution analyses. I always think of it as more of like a global picture. And I think even for the individual that is someone like let's just look at Simon Hill versus like Paul Saladino, both seemingly very healthy individuals. Like, do I think that, Simon Hill is going to outlive Paul Saladino by a lot because he is on his specific dietary pattern versus Paul Saladino? And if I was a betting man, I would bet that they probably would both live to a ripe old age and pretty happy doing it. So that's what I hope for, at least. So
let's talk for a moment about, you mentioned machine learning. I got to say, I'm having a lot of high hopes for artificial intelligence. I don't know if you knew this. I originally, when I was first getting into software development, AI is where I wanted to go. But at that time, it just wasn't, the processing power just wasn't there, nor was storage. Storage capacity needed to be ridiculous to meet what I thought was exciting then and is now more commonplace, which is neural networks. Large language models are, I think, it's currently changing all of our lives. What I especially like that's fascinating is the promise of being able to have greater objectivity. Now, to be fair, it's the potential, but not necessarily the guarantee, because the nature of how these things work, you can still impose some amount of top-down training. And we already see that in how much they kind of recirculate not only conventional wisdom, but as I was chatting about with Peter, they have business goals. There is a survival component to these models in that they cannot be too renegade against conventional science that's out there, lest they draw negative attention to the business that underlies it and feeds them, right? But ideally, we would work at making AI that could make decisions without these political influences on the outside and give us real answers, where I think medicine really needs it badly. So, for example, I probably would never accomplish getting an independent analysis from the CTT. But it would be interesting if there ever was a requirement for at least an AI to be able to, sorry for anybody who doesn't know the CTT, they're based out of Oxford. They effectively have a monopoly on the data from cholesterol trials. I think it's the cholesterol trialists something. And that's an amazing data set. It's gigantic. But they pretty much only release meta-analyses that are favorable towards cholesterol lowering, or further establish that high cholesterol is bad, or even moderate cholesterol is bad. And this isn't to say that I'm insistent that there's some wrongdoing there or anything along those lines, but you never know how much there is motivated reasoning with all of us. We all do it to some extent. It would be great to get a data set like that under some objective methodology that could come through an AI, and you could correctly point out, hey, and it's independent. This entity that's going to be doing this analysis can be set up to be a priori for what we really care about. And obviously I'm interested in trying to look at the subset that could get closer to what we're looking toward with, say, lean mass hyperresponders, while also being able to be truly hands-off. It could actually remain blinded in and out. Something like that just wasn't really possible without a lot of pre-programming. But with these models, you could do prompt engineering and get that situated pretty quickly. And it could happen. It really could. Now, do I think that they'll be, opening their arms to something like that? I don't know about that, but it's possible. That's exciting.
It is. And I think you hit the nail on the head, though. And I think as a candid moment with you and Ethan Weiss's interview, I don't think that there's any sort of incentive to do that by, the individuals that have the most to gain from certain interventions and things like that.
Isn't this crazy, though? You're being a pharmacist. You know how these drug trials go. Of course, it's to a greater business benefit for it to be assumed that the drug applies efficacy to a larger and larger population. Of course. Right.
Right.
Okay, but from a truly medically ethical standpoint, we should want to feel confident that we're putting people on the drug for which there's population data to support. They are benefited. And if there's a subset that's either not being benefited or worse, that we can feel confident there's a detriment. They shouldn't be on the drug, right?
Right.
How do we enforce that?
I don't know.
If the data is proprietary, what do you do?
I don't know. And I do wonder about that a lot too. I mean, there is observational data too, for example, in Korean populations on statin medications that I think I just tweeted about like a couple of days ago, that individuals that were categorized at low risk taking statins had a higher risk of MI and MACE. I mean, so I do wonder about, that subset of the population that, I wish we had higher quality data, and I wish we didn't have a lot of incentive and we could take away the bias that human beings inject directly and indirectly. But I wish there was a good way around it. I mean, if you figure out a way, Dave, I'm all in, because the more objective we can be with respect to the way that we analyze data and output data, the more we're going to actually advance as a human civilization.
Agreed. Well, I can say that I am participating in that with Own Your Labs. Own Your Labs, we're trying to, but we're not going to come anywhere close to these studies that are hundreds of millions of dollars. I'm hopeful. I'm optimistic that there's going to be more and more of a move towards transparency as more and more of this does get aggregated within these models. Again, assuming that they can be used for good instead of evil.
I'm hoping that the public too demands this as well. I feel like we're seeing this kind of trend where, people are just kind of fed up of being fed a bunch of nonsense, and that, hopefully the market will push towards that being the case. Obviously there's still ways around that from the powers that be, but boy, I think people they really just want the truth. And they really want the nuance too, and they're not too dumb to understand.
I think so. I honestly feel like my mind has been changing on that, because for a little while I kind of felt there was a lot of complacency. But I do think that that's changing, and I think that there's a lot more interest in certainly transparency. Again, I feel like I've watched it change in real time over the last few years. So hopefully it holds. We'll see.
I hope so too.
All right, I suppose we'll complete our marathon here. Unless there's anything else you could think of you'd want to fit in real quick.
I mean, there's probably 5,000 more things that I wanted to chat with you about. But I mean, honestly, the thing that maybe if we ever get to do it again, was...
Well, that's the other thing, is you're going to for sure be coming back.
Yeah. Well, here's what I would say is if epi isn't good enough to figure out, what's right for human beings to eat, how do we figure that out? And I think that could pose a lot of really interesting questions. I think it's kind of what Ken Berry is trying to do with this whole proper human diet thing, and
we can okay, so you can still apply Bradford Hill to epidemiology and hit a high Bradford Hill threshold. You absolutely can. I'll bet somebody who's only eating donuts.
Yeah.
Right. Or let's say they have a family and they're only eating donuts, will hit a high Bradford Hill threshold of donuts not being a stable dietary intervention of complete nutrition. I think that's going to happen quickly, right? Strictly through observational data. Not that you even need to say, I know for sure it's causal, but just that I have enough information, which is what we've done with smoking, to feel confident enough in the causal inference I'm rolling with, right? It's the same thing, by the way, with trans fats. With trans fats, that was also a causal inference that just had enough of a strong opinion behind it that everyone was pretty much in agreement. Red meat is not one of those things. Currently, it needs a p-value and it needs a lot of statistics to get us to that point, right? And it needs a very low hazard ratio in comparison to what Bradford Hill himself would have wanted.
And not to mention too that, there is a risk and benefit to every single decision that we make on planet Earth. And even if, avoiding red meat for the rest of your life did cash out to some, benefit as far as cardiovascular risk goes, that might be for an individual worth that specific trade-off too. You run a nominal risk of dying in a car accident every single time you go to the grocery store. Well, we know that trade-off is, worth it in that regard. We don't want to walk to the grocery store every single time we get groceries. And so likewise, again, too, maybe that holds true for, other types of dietary exposures and things like that. With trans fats, it's we could remove them from the food supply. It was an artificial additive to a degree that was that, we saw a signal of problems in it. I wonder if the signal with, red meat in particular was exactly the same as trans fat, whether or not we would, move on that as well too. And I don't know the answer to that, but I would say that a lot of people really do enjoy those components in the diet too.
Right. That's the major difference is there's not a pushback. If there was a trans fatless Monday, I wouldn't see a bunch of protests around it. I would see a bunch of people go, oh man, that's terrible. A meatless Monday, different story.
Right.
Now you have a number of people who say, wait a sec, what is the evidence? I'm very interested because if you're wanting to talk me into something that's on weaker evidence, but for which almost all of us are pretty blasé about changing, we're like plausible enough on top of lifestyle impact being low. Okay, fine. That's one thing. But this is why epidemiology is absolutely useful. It's absolutely important for us to keep it on a spectrum. How much we think we can feel confident in a claim of causality versus how much it would take to change it versus how much we don't want to change it.
Right.
All of that's relevant.
Absolutely. I agree.
All right. For sure you're coming back, but thank you for coming out here, Austin.
So much fun, Dave. Thank you for having me. I really appreciate it. So it was a wonderful time. It's always great to chat.
How do people find you?
Oh, yeah. My old Twitter is still suspended. I got it back, but then it got resuspended again after I sent a DM about the PESA analysis to some people. Anyways, Twitter handle is @APODuds.
And that's with a Z.
And that's with the Z.
APODUDZ.
Yeah. And then my other Twitter handle, for a lot of archived evidence, if anybody's interested, is @DudsLightLime. DUDZLIGHTLIME.
Okay, but if you remember the first one, you have a link, I think, in your bio to the
Yep.
second one, so they can just go there.
Yep.
Thank you so much for coming on, Austin.
Thanks, Dave. Appreciate it.